All right, Morgan, it's all you.
Oh, perfect. Okay, so we're gonna dive into shock. Um, that when we talked about the VQ mismatches, this is the Q. Um, if like blood supplies gets disrupted for whatever reason, uh, the patient starts going into shocks. Um, so shock is defined as inadequate cellular perfusion, any compromise in perfusion that can lead to cellular or injury or death. In the early stages, the body attempts to maintain homeostasis. Does everybody know what homeostasis is?
Complete balance.
Yes. Yes, balance. Our It's kind of like yin and yang. Our body wants to stay level, and any disruption of that, the body attempts to correct. So diffusion is where we have a concentration of like oxygen in the lungs and less oxygen in the bloodstream. So in the alveoli, it carries over to the alveoli, and the CO2 carries back over to the blood, and we exhale. Like they were saying there, and then back down in the cells, the vice versa happens from the blood to the cell membranes, and then the waste and the carbon dioxide gets transported into the blood, and uh, and then so the excuse me, the oxygen gets transported back into the blood. CO2, the oxygen goes into the cell membranes, and the CO2 goes in the blood in the waste, and it gets exhaled. Um, so if the body or the cells aren't able to diffuse their waste like they're supposed to, uh, they go, they start breaking down oxygen, or they start making energy without the use of oxygen to keep like themselves alive, and but they build lactic acid up, which is really not good, and it messes with the body quite a lot. Um, so early recognition can save lives. Obviously, shock is a state of collapse or failure of the cardiovascular system that leads to inadequate circulation. It can like we can we're trained, like Kevin and I are trained to look at it, and you'll be able to see once you start get going, like if somebody's like sick, and then we talked about it yesterday, like sick or not sick, you can walk into a room and you'll be able to like, oh, this person needs to go quickly. So there's three components to the cardiovascular system that the shock, which affects with shock, the heart, which is the pump, the vascular system, like the piping or whatever, and the blood. Um, so again, here's the heart with its four chambers, and so like if the pump needs the, oh my god, so so this is, oh my god. S-
Hey, Morgan,
So,
can you go back one? Can you go back one slide for a minute?
oh my god, yes.
Yeah, you're fine. I get it. Shock is definitely something that's very confusing, but yet it's very simple. Understanding like the background of what's really going on with it. So there's different types of shocks that Morgan's going to be covering moving forward. There's cardiogenic, which would be the heart, right? Then we have distributive, which would be, as you can see, distributing throughout the entire body, right? Then we have, which would be more like a septic shock, more distributive, right? Then we have anaphylactic shock, which would be of the, excuse me, I just lost a train of thought for a minute. The anaphylactic shock, more of like an allergic reaction that turns into full-blown anaphylaxis, having a widespread issue, where we look for like chest pain, shortness of breath, urticaria, hives. And I'm going to start utilizing, by the way, just keep in mind, bigger terms. So if I say urticaria from here on out, understand that means hives, right? Distributive shock versus going into a specific type of distributive shock. I'm going to say septic shock, neurogenic shock, right? We also talk about hypovolemic shock, which would be a lack of fluid. And that doesn't have to just be bleeding out. That can be a loss of any kind of fluid balance that changes that homeostasis within the body. And the word homeostasis, the way to put it is like an even playing ground. Our body has to meet a certain degree of electrolytes and blood volume and things like that, oxygen levels to meet that homeostasis. So if I say homeostasis, that's the even playing ground of the body that's that we're currently working with, right? And any deviation can change that homeostasis. So looking at the cardiovascular system and that consists of the three parts that are here, we have the pump, which is the heart. We have to have a pump. Now everybody talks about, and then we start looking at like higher license levels. Let's just start giving pressors, right? Let's give them something to bring up that blood pressure. That's great. But the medications we're giving causes that squeeze, but if there's nothing to squeeze, it's not going to work. So we got to fill the pump. That's what you call for ALS providers. They fill the pump with fluid. And then once the pump is filled up, kind of like priming your pump, you guys have done that before, the pump has to be primed. So looking at the pump itself, we have something called preload and afterload. Preload, blood coming in, right side of the heart. Afterload, pump being squeezed, pushing blood throughout the body. And that's what we're going to show and Morgan can kind of cover in the slide. The set of pipes are your blood vessels, your arteries, right? So if you look at, for the firefighters in the room, that's your aorta, arteries, right? Going into your arterioles, into your capillary beds. You have to have good perfusion. So going back to what we talked about in the last class, what is another way that we can measure perfusion status? Or give me some examples that can measure perfusion. We'll start with that. What are some things you guys can do to measure or look at perfusion?
Sweat or lack of.
Lack of, right? Okay. So now you may see that with hypovolemia. What else could you see though?
Color of skin, pale, grayish.
Yes. That's what I wanted to hear is your pale, cool, clammy diaphoresis, that white look, right? The grayish color. That's a patient who's in shock. What else can we use to measure perfusion? There are a couple other things we can do.
Do a C.
O2 levels.
How about do? Sorry, I missed that. You said O2 levels? Is that what you said? Sorry, I missed that part.
Yes.
Okay, so we can look at SpO2, but what do we off gas?
We can do the cap refill.
Cap refill is another great sign. Exactly, I like that one there. What else do we off gas? What comes out of our respiratory drive? Things that are off gassing. What is that called? And I know that I covered it during patient assessment.
Is it the end tidal?
End tidal, exactly. So measuring that carbon dioxide, looking for those numbers of 35 to 45 to make sure our body is perfusing appropriately. All right. So we have cap refill. What about blood pressure? Can blood pressure measure our pump and our fluid?
Yep.
Absolutely.
Yeah, absolutely. We can look at our systolic versus diastolic and our mean arterial pressure, right? So one of the things you look for in shock, talking about our pump and our contents, is if we have any kind of change in our vascular, okay? Our vascular changes. And to go one step above, because I want you guys to be smarter than the EMT, right? We start seeing alpha receptor effects. We're starting to see that change. That's our pathophysiology behind it. We're seeing that change in our alpha receptors, alpha being vascular. There's going to be medications that you guys are going to be giving in the field, right? That are like nitrates, for example, causes vasodilation, has alpha effects causing that. We give albuterol, right? That's an EMT medication that has slightly alpha effects, but it also has beta effects controlling heart rate because it's a sympathomimetic. We'll talk about that in pharmacology, right? And it also has effects on the lungs for that smooth muscle that assist it with the dilation to allow for bronchial dilation or bronchodilator, and that'd be beta 2. So we do have receptors in the body you need to be familiar with that are going to help with that. Let's go back now to what I was talking about here with the cardiovascular system. Shock can cause widespread vasodilation. Dilation is bad, right? Because what happens when you take your vessel and you make it bigger? What do you expect to see? What do you expect to change with that?
Your
Blood
blood
pressure.
pressure is going to go down.
I heard blood pressure, and I think everybody else agrees. You're going to see a change in blood pressure. This is why our septic patients have widespread vasodilation due to something called bacteremia. Bacteremia, or bacteria in the blood, causes that widespread vasodilation. Widespread vasodilation then also in turn can hurt the kidneys, because your kidneys can no longer receive blood because it's one of the last things to get it. Therefore, you're not filtering, and you start losing that blood flow to kidneys. Before you use your output, you see how it goes in the past, and if you're now you're not fluids. Now you're retaining stuff. Widespread
Kevin.
dilation. Now you start having multiple organ system dysfunction. Right? It all
Kevin,
goes in.
can
I
you
know
hear
this is
me?
confusing. Yeah.
Kevin,
Hello.
hey, you're like fading in and out, and kind of like you're on a radio.
And not waiting for the pause.
Yeah,
Oh, sorry.
that's all right.
Now you
Is that
sound
any
good.
better? Is that
Much
better
better.
now?
Yep.
So when you were talking about the kidneys shutting down, is that when you're saying like septicemia?
Yeah.
That's people are
Yeah,
going to be
exactly.
septic? Okay.
Exactly. Because we're pulling too much other blood away from the body, we start seeing things shutting down. And this is what Morgan is trying to tell you is shock is very dangerous. Shock kills people because of that vasodilation or lack of fluid, the contents of the blood, right? You have to have a pump, you have to have pipes to push it through, and you have to have contents to push it around inside and out. That's why, and then again, going into paramedic level stuff, and again, all this is above and beyond your scope. If Morgan gives somebody a pressor without filling the tank first, there's nothing to squeeze, right? And now we're just dumping these medications into these patients. They're going to kill their kidneys. Next thing you know, they're going to be getting dialysis for acute kidney failure, right? So there's a lot of things we look at, even at the basic level of what we're doing at EMT, that we give medications, we look at patients and see how they're perfusing. And the lack of perfusion, or the term for shock, inadequate state of tissue perfusion, can change the outcome of the patient if we can see the difference. So we can do things like warming the patient up. We can give them oxygen, not too much. We don't want free radicals in the system. Free radicals are bad. We don't want to wash out our nitrogen. Nitrogen plays a big part in oxygenation as well, right? So there's a lot of things that we can do in the field at EMT level, keeping the patient warm, elevating their legs, old school, by the way, what they call Trendelenburg, by taking and moving the blood back to the core. Shock also starts shutting down peripheral vasculature. Okay, so we see that pathophysiology, that those pipes, things start shutting down to keep the core alive. And one of the first signs you're going to see in shock when you start getting into the organs is people are going to say, I feel nauseous. I don't feel good. My stomach hurts. So they're going, oh, we're going to call for a paramedic to give Zofran. That's not the answer to that. They need fluids, not Zofran. They don't need an antiemetic. What they need is fluid to get out of that shock-like state, because the first organ to shut down is your stomach, which is why you start getting that nausea, right? So look at our assessment and ask those pertinent questions and those pertinent negatives: chest pain, shortness of breath, nausea, vomiting, diarrhea, dizziness, headache, blurry vision. All those pertinent questions you want to ask. Because if you have someone who's had multiple bouts of diarrhea, right, it's not just stomach contents coming out. What else are they getting rid of?
All their electrolytes, their good flora.
Exactly. Electrolytes. And one of the biggest electrolytes that we're seeing being depleted out of that is potassium, right? And when we get into our cardiac
Can you repeat that?
assessment, it's potassium.
Potassium. Okay.
Yeah. And there's three major electrolytes that we deal with. And again, I'm not going to get in detail with those: sodium, potassium, and calcium, right? And you're going to learn more about that in cardiovascular emergencies when we start getting more in depth. But there's something called a sodium potassium pump that helps pump the heart. And if you deplete something of that, what happens? Now our heart can't pump, right? I went a little more in depth on pathophysiology with that, but now you have an understanding looking at it too, that if our heart's not pumping, why isn't it pumping? We got to figure it out. And we're going to cover more of that later on. We talking about Beck's triad and things like that in cardiovascular stuff. But again, thorough assessments, even at the EMT level, truly does help save lives. So I didn't want to steal Morgan's thunder on that, but I just wanted to have you guys understand that there's a lot to be as far as this stuff goes, is the pump, pipes, and contents, right? You can't pump without fluid. If you have no fluid, the pipes can't fill. If the pipes are dilated and there's lack of fluid, we have lower blood pressures, right? And you have to have contents inside. You've got to move. You got to have red blood cells to move hemoglobin. Hemoglobin has to move as oxygen transport. Without oxygen transport, our cells become less perfused. So some of the first things we should be checking and the pathophysiology behind it would be the furthest away from the extremity, right? So people are like, oh, well, we check the radial pulse, they're in shock. Check a pedal pulse. Because if you don't have pulses in the dorsal pedal, you're not getting enough pressure down there to perfuse. Cap refill in the fingers may be different than cap refill in the feet because it's farther away from the heart. Are we fully perfusing our body? And that goes back to the same thing we're seeing here. Pump, pipes, contents. 3 things. So does that make a little more sense on that slide?
Mhm.
Do you have any questions on that? I kind of went a little overkill, but it's good to know. Any questions?
Not yet.
All right. So like Zach would say, is this clear as mud right now? All right. Morgan, it's all you now. If you want to go to the next slide, I just want to kind of get you back on track.
Oh, thank you.
You're welcome.
So like Kevin was saying, the pump, there's a heart. We'll just go over it quickly. 4 chambers, like there's 2 different separate pumps. Which artery is the only one that has deoxygenated blood in it? Does anybody remember? Just quick.
Pulmonary
Pulmonary.
artery.
Okay. And what's the one that has oxygenated blood? Lower here.
The pulmonary veins.
Yes. Anything that comes back is a vein, and anything that's going out is an artery. So, and if, like Kevin was saying, like the veins and the can dilate and constrict, in the heart, it can fail. Like when people have cardiac failure, it doesn't pump the fluid effectively, or the blood. And then people also like lose fluid or blood, or if they're bleeding out somewhere. And it doesn't take a whole lot to get things mixed up. So the perfusion triangle, the heart is the pump function. The vessels are like pipes, and the blood, it's the what gets pumped around and carries all the good nutrients and oxygen to the cells, well, and then take all the waste away from the cells. Blood pressure and the pressure of the blood at any moment. So we always have pressure going on with our in our system. I don't know if anybody's like been in the ICU or whatever and seen an A line. Like there's always real time they're doing blood pressures. But so our system's always has some sort of pressure going on. It's either like when the ventricles are pumping against the resistance of the walls, or like when it's at rest, there still has to be pressure.
So what's really cool, if you want to go back just 1 second.
Yep.
All right. Okay. So we have systole and diastole, right? So systolic, diastolic. Like Morgan was mentioning before, the peak arterial pressure. Let's go one step further. What it's measuring is your left atrium, left ventricle pressures, not the right side of the heart, but the left side of the heart. So you take a blood pressure on the arm, right? You're measuring it through the brachial artery. You notice I said the word artery, correct? We're measuring the blood pressure on the arteries. You're going to have higher numbers. 120 over 80 is your normal blood pressure. That's the perfect textbook blood pressure. 120 is systolic, diastolic of 80. You're not measuring the right side of the heart. The right side of the heart will have even lower pressures, which you cannot monitor outside of the body unless you start doing pulmonary lines. And that's something that's called critical care, right? We don't deal with that at the EMT level. But I like giving little tidbits of side information. A normal blood pressure for the right side of the heart is 15 over 5, right? So that's a normal blood pressure for the right side of the heart, monitoring those different lines that he was talking about with arterial stuff. But with arterial lines, this is more of a pulmonary, but arterial lines, like he was mentioning, which are pretty cool in the hospitals, give you real-time blood pressure. Constantly, constant pressures, right? So that's kind of what he was going with that. But we need to know, as an EMT, is systole and diastole and the difference between the two, right? So peak arterial pressure and pressure in the arteries while the heart is rest between heartbeats, right? And to me, diastole is more important, because if your diastolic blood pressure number is 160, is the vessel actually resting? Yes or no?
No.
No. So if you have a blood pressure of 280 over 160, what can happen?
Boom.
Oh, an artery.
I heard boom.
That was me.
Yeah. Heart attack, strokes, hemorrhagic vessel strokes, like the actual bed bleeds. Right? Cause and effect, everything that we do. All right. Sorry, Morgan. I just want to kind of add that in.
No, don't be sorry. I appreciate it.
Okay.
And so actually with blood pressure, does anybody remember the talk when we were talking about the mean arterial pressure? I mean, not the mean, the MAP. Yeah, the mean arterial pressure.
Is that the difference between the two?
When we were doing the show and tell with the ambulances, we were talking about it. The systolic plus diastolic divided by 3.
By 3. That's right.
Right. And then we wanted to keep it at least above 60 for perfusion.
Keep track of those numbers, because one of the things I'm going to quiz you on is septic shock, and a mean arterial pressure less than 64 is what they call it's called a SIRS, SARS, which is part of the systemic inflammatory response syndrome. We'll go over more of that in shock, but don't forget your MAP. It's very important.
So pulse pressure is the difference between the systolic and the diastolic pressures. The significance, so the systolic is what it's using to push the blood through the vascular system, and the diastolic is when the cardiac is at rest, but there's still obviously pressure in the vascular system. A pulse pressure less than 25 may be seen in patients with shock. So that's probably a good number to remember. I've never. Blood through the capillary beds and is regulated by this capillary sphincters under the control of the autonomic nervous system. Regulation of blood flow is determined by cellular needs. So does anybody know which one is the most greedy of the organs for nutrients and oxygen? Anybody?
Which one of the organs is the most needy?
Yes. Which one is the body going to protect the most?
Lungs? The heart.
No,
Spleen.
the brain.
Nah, who needs a brain?
Duh.
Scarecrow didn't have a brain.
Right.
Yeah, he couldn't
So,
stand
that
up
is
straight
true.
either.
Um,
So the brain.
our body, when we start to go into shock, our body will start shunting, like Kevin was saying, blood from our extremities more into the core and into the brain.
Yeah.
And so,
So-
like he was talking about before, if you have a patient that's shocking, you stand them up, they're probably going to pass out. But if you do put them in the Trendelenburg position, it's going to bring blood supply back into their head, into their core. So, and it is old school. I just used it a few months ago, and it was very successful. Kevin, go ahead.
The other part, though, on top of that, is also keeping the patient very warm. Right?
Yes.
So yeah, because remember, cold constricts blood vessels. Right. We don't want that to happen. We want to make sure they're actually perfusing appropriately. The other thing too is, as I heard Morgan mention, pulse pressures. Take note of that definition, because you're going to see that come back and haunt you later. And trust me, I promise you, I'm going to haunt you with that later. We start going over scenarios and medical stuff, because narrowing pulse pressures or pulse pressures getting close together is something you're going to see in Beck's triad for pericardial tamponade. And I'm going to quiz you guys heavily on that. All right. Quiz you guys heavily. There's 3 things for pericardial tamponade you need to remember. Narrowing pulse pressure, so blood pressure, systolic and diastolic being close together. The second thing is muffled heart tones. And the third thing is jugular vein distension. If you have those 3 things, that's what they call Beck's triad. And it's indicative of pericardial tamponade, which can happen in trauma. Okay. So we start talking about cardiovascular stuff and trauma. I am going to quiz you guys like you wouldn't believe on Beck's. Right.
Okay.
Beck's triad and Cushing's triad are the 2 big ones that I hit you guys on, because they're very important to understand. I'm not going to go over Cushing's right now because we're not talking about neurological assessment. But Beck's triad, though, definitely. So I would take note of those 3 things, because I guarantee you that I'm going to quiz you guys in person or on lectures of what that is. All right. Sorry, Morgan.
So sorry, I appreciate it. So perfusion requires 3 things: oxygen exchange in the lungs, nutrients that go from the form of glucose into the blood, and waste removal primarily through the lungs. So a lot of the way our body corrects our CO levels is through breathing. The other one's through the kidneys. But like if you see somebody that's breathing fast, they're trying to blow off CO2, or they're acidotic, and if they're slowing down, they're trying to keep the CO2 up. Like I think Zach talked about it a week or 2 ago, where somebody who's hyperventilating, they're just kind of keeping their CO in, and so their body tries to correct it, and then that's when they pass out. So we'll get in more into the form of glucose in the blood in the endocrine emergencies, but so if glucose is too low, it uses glucose in order to make energy into the cellular level with the oxygen. I don't even remember what that's called. Kevin does, but you don't. It's a paramedic and above, but it's important. Mechanism in place to support respiratory and cardiovascular system that need perfusion, and the vital organs is increased, and includes autonomic nervous system and hormones. So when our body, like when we start losing blood or feel like we're going in the shock, our body has kind of fail safes in order to keep homeostasis in balance. So if we're losing too much blood or whatever, our heart rate will, our adrenal system will kick in epinephrine or adrenaline to like pump up the heart to get it beating faster and then constrict the vascular system. So if you see trending with vitals going up, respiratory rate going up, and blood pressure going up, then you know they're going to start to go into shock.
And that Morgan's saying that's your sympathetic nervous system kicking in, right? That's your fight or flight. So
And you said the blood pressure is going to go up. Doesn't it go down?
It goes up first.
It
Oh,
goes
okay.
up first, and that's going to be your compensated shock. You're going to start seeing things starting to change. You might see like a normal tension or a little bit of hypertension, but you're going to see more of a tachypnea and tachycardia first, right? So your body is releasing a neurotransmitter, which is something you guys learn in pathophysiology, right? Is a neurotransmitter, norepinephrine. Epinephrine is a hormone. It's not a neurotransmitter. There's a difference between the two, right? So we're seeing that norepinephrine being released. Now we're seeing everything starting to increase. So you'll see the sympathetic nervous system take over. And it's good to have an understanding how that stuff works because, again, there are medications that you administer, epinephrine being one as an EMT, and the second one is called a sympathomimetic, which we'll cover in pharmacology. But sympathomimetic is something that mimics the sympathetic nervous system to have that increase. And one of the big ones is albuterol. And albuterol is one of the medications you can administer. See how a lot of this stuff's tying in, right? So I guess it's not really shock that we're talking about as far as the meds, but everything ties into something, right? And that autonomic nervous system, the parasympathetic and sympathetic system, which you guys need to know as an EMT, not the in-depth into like all the hormones and stuff, but the transmitters that are there. What you're going to see in the old school feed or breed, the decrease for the neurotransmitter being acetylcholine, bringing it down, or you have your norepinephrine neurotransmitter being released to bring things back up again. So if I walked up to Fred and I punched him in the face, he has two choices. Either he's going to fight me or he's going to run the other direction. Either way, his sympathetic nervous system just took over. And that's what they call the fight or flight, right? If he's going to bed now because he's all embarrassed, I just knocked him out, right? And he goes back home, but he's embarrassed and goes to sleep. That parasympathetic system kicks in, that feed or breed, and things start slowing back down again. Does that make sense? Don't worry, Fred. I know you're safe. I know you're from Massachusetts and all, but we're good. We're good. So hopefully that was a little more of an explanation, Morgan, on that stuff there, because that's what Morgan's going to be getting into is this.
It all made sense except for the part that you knocked me out.
That's it. All right. I'll stop yapping for now.
No, you're good. So hormones are triggered when the body senses pressure is failing or falling. So like I was saying, the heart rate increases, the strength of the cardiac contractions increases, which is the blood pressure. Like your heart is like going to pump harder and more, try to compensate. And then your peripheral your peripherals will start constricting to like pull more blood supply into the trunk. This response causes all the signs and symptoms in shock. The three basic reasons that people have shock are pump failure, poor vessel function, and low fluid volume. So like when people have heart attacks or whatever and they damage their heart, it's not working properly, and then fluid will start building up into their body and cause third spacing and all other sorts of things. And it's not pumping effectively. Or when people have wicked bad hypertension and can't get the blood into the lungs in order to get oxygen, it starts backing up into the system. And then also like people who smoke a lot or whatever, they're just have a lot of issues. Not just people that smoke, just if there's genetic issues with vessel function, they will not work properly. And
Morgan,
like,
is low fluid volume like a blocked artery or something to that effect?
It could be.
not dehydration.
What's that? I didn't.
The low fluid volume. That's like if an artery is blocked or if something's causing
No, low fluid
fluid not to
volume would
flow.
be like Kevin was saying, like somebody who has diarrhea can, especially
So
the
like
elderly.
dehydration.
Yes, like the elderly
Okay,
is
all right.
Yeah.
prone for it.
Got it.
Small babies are prone for it. That's why it's always important to make sure babies are well hydrated more than anything. Like he was saying, like when people go into anaphylaxis or when sepsis, it's distributive. Like their vascular system just opens up, but it just depletes the volume because we only have a certain amount of volume, and if it opens all up, then we can't replace the volume unless we start doing IVs.
Right.
Okay.
And the thing is, like Morgan's saying, is that the poor vessel, that'd be poor vessel function, because now we're seeing that widespread vascular dilation, right? Which is why we give something called vasoconstrictors like epinephrine, things that can help with that. But the diarrhea, the vomiting, or the active arterial bleed or internal bleed, that's your volume. That's your fluid volume, right? Pump failure, but pump failure really is that's your cardiogenic issue, right? Cardiogenic shock. That's your pump. Your pump actually failing. And it's not going to be normally just from electrical stuff. It's going to be because of other kind of diseases. So the thing we look for is, and to kind of answer the question that I think it was Fred that was asking, maybe Fred, blocked arteries. Okay, what is an artery? It's a vessel, right? So that'd be a poor vessel function because we spent too much time in Old Orchard Beach eating all the pure fries all this time, right? We've put up all that plaque and everything else and just kind of blocked everything. So think of a vessel issue as your heart attacks, right? Your MIs, where you have your blockages in the coronary or circumflex arteries in the heart. Right? Does that make a little more sense?
Yep.
Right.
Again, pump failure, the cardiogenic shock, when somebody's had heart attacks or whatever, blocked arteries, and it's not pumping effectively. Low fluid volume, like what is it, 75% of our blood is made up of plasma, and if we don't have like enough fluid or whatever, it won't be able to pump. Like you're a firefighter, right?
Yep.
Yeah. So like what happens if you start running low on a pump or your reservoir? It's not going to be able to.
You don't get any output.
Right. So same thing. And then like, can you spray water with a 4-inch hose as far as you can with a 2-inch hose? You can,
No,
but you have to have
right.
a bigger pump.
Yeah, the bigger pump, right? Bigger pressure. Yep.
And more
So-
fluid.
More fluid, because you're going to need a lot more water to get it out there.
That's a great analogy.
What's that?
The whole hose, the 2-inch hose versus the 4-inch hose. It's not just the
Oh.
pressure, but you actually need to have enough volume too.
Yep.
That's true until you start getting plaque buildup. Then what happens to that 4-inch hose?
Yeah. Becomes less than
Right.
Becomes a 2.5-inch.
And then the patient starts becoming ischemic. They start getting chest pain and angina. And we're going to cover all that in cardiovascular emergencies too. See, it all plays in one big picture.
So what's that?
Getting back to homeostasis.
Yeah, that's what our body's always trying to do. So these are some of the reasons that for the causes of the shock, the pump failure or cardiogenic shock. So attention pneumothorax. That's when. So I don't know if we talked about it. If somebody like breaks a rib or whatever, or punctured a lung, or an auto pneumothorax with like white males whose lung just burst for whatever reason, like their air will start. Yeah, we did talk about it. Scott gave us a scenario with somebody who had a tension. And so like it's going to put pressure on the heart as well as not just the lungs, so the heart won't be able to pump effectively. And then Kevin was talking about the cardiac tamponade. That's when the fluid, like if you get hit in the chest with like a baseball bat or something, and your heart bruises, it's gonna swell up, and you're gonna get fluid in your pericardial sac, which is the sac that goes around the heart, right? Peri means around, and cardial sac. So you're gonna get excess fluid into the, and so they're. I gotta put my camera on. I'm like using my hands way too much. And there you go. Can you see me? So
Yes, we can
again,
see you now.
oh, good. So like you get the sack, and then somebody like punches you or whatever. And I think wasn't there a football player last year who got hit really hard in the chest?
There was. That
And
caused the commotio cordis.
there you go. So that would
Yeah,
be
commotio cordis, which is the RNT phenomenon they talk about, where they hit him on that EKG on the QRS. So on the R wave, it actually hit the patient at the right time, putting the patient in the ventricular arrest.
right. So that'd be cardiogenic shock because the heart was not working anymore, or effectively, it was working, but it was way too much. But
So
yeah,
Morgan, the stuff
ma'am.
that's the obstructive shock, will
Okay.
that just, the tension and the tension pneumothorax and all, and the pulmonary embolism, then does that cause the cardiogenic shock?
Yes,
Okay.
because it's whatever makes the heart not pump effectively.
Okay. So cardiogenic shock is a very, a broader term.
Yes.
Okay.
So distributive shock, the poor vessel function, is when patients like septic shock. Oh, I actually I wonder if I can find it. A neurogenic shock. That's like when you scare somebody and they kind of just pass out. Like, the goats that pass out, like if you scare them, it's kind of like neurogenic shock. You just kind of like there's like the fight or flight, and then there's freeze. That's kind of the freezing. Anaphylaxis, your body just goes into overdrive mode and thinks something's there to harm it, and it just your vascular system just dilates. And psychogenic shock. Kevin, I'm phoning a friend. He's not there. So low fluid volume is like hemorrhagic shock and non-hemorrhagic. So if somebody's bleeding out, they're going to have low fluid volume, and then so our jobs is to correct it, like stop the bleeding, or for you guys, like put a blanket over them, put their feet up, and yeah, just keep them warm. And like if it's 90 degrees out, you crank the heater and you sweat it out because your patient's more important.
Morgan, the psychogenic shock, isn't that when you faint?
Yes, thank you.
Yeah. Well, when that
it's
happens,
like if somebody gets bad news or something.
right. And
You know
so
what I mean? Like, exactly.
it's okay if you're nauseous after that, right? I mean, because you are going to get, because like people when they do faint, I've fainted and I have felt really nauseous and actually had to take Zofran, but that's a totally different scenario, correct?
That's
Okay.
correct. So you're not having it. You're not having that low fluid volume. You're not having that.
Right.
That's the vessel function, as in like septic shock or neurogenic or anaphylactic. So the psychogenic shock would be more like, hey, someone just passed away in your family you're really close to, or you're a sudden death, and you just take that big hit.
Yeah.
Again, we'll go more in detail on these things here in a little bit too.
Right. Oh crap.
And what was the non-hemorrhagic shock?
So somebody who has diarrhea.
Okay.
Someone who's
I see
not bleeding.
Yeah.
Someone not bleeding?
Yeah, if you want to look at it that way, someone who's not bleeding, that non-hemorrhagic,
yeah.
hemorrhagic being blood, right?
Gotcha.
So excessive vomiting, excessive diarrhea, things like that.
Heat stroke would be another one.
What about burn victims?
That's a whole. They could definitely get shocky.
Well, they lose all that fluid.
Yeah, they lose a lot of plasma.
There's a whole different world with burns, and we'll
Yeah,
talk about that during our environmental and burn stuff. Because you got a patient that's going to be hypovolemic. A patient that's probably going to end up being septic, right? There's so many different things that are going to happen with burn patients, and our fluid resuscitation with burn patients, like for ALS stuff, is completely different. We follow something called a Parkland formula for that. So burns are a completely different animal because there's so many different things that can happen with infection, things like that, along with hypovolemia, the hypothermia. Now their pores are open. So I mean, there's so many different things that can happen with these patients that are burns.
So that they
And I
are
don't
their own animal altogether.
Absolutely. Yeah,
Okay.
they could have a bunch of different things going on that we need to start treating, and there's a lot to do with significant burns. Now, a superficial burn, yeah, whatever.
Right.
Here's some ice, and we'll call it good and send them home, type thing. But you start getting into your 3rd-degree burns, and you start getting down into the deep tissue, right, or more of a subcutaneous layer of the skin, and to the point where they actually burned out their nerve endings. That's open for significant infection into the body.
So shock is the least of their.
Oh, they're going to, yeah.
I mean, because I'm thinking they're losing all that fluid right off the bat. I just didn't know which part of the shock, like what category that would fall into. But it sounds like it falls into just about every one of them.
Yeah, so they're going to lose a lot of fluid. You'll see that non-hemorrhagic hypovolemia,
Right.
but they're also
They're
going to
both-
become hypothermic.
Right.
They're going to
They're gonna have
probably
septic.
become septic. They're going to be getting a lot of antibiotics, of antibiotics for burns. And we're not going to discuss antibiotic therapy in this class, but that's a whole different game. But there's a lot there. Our biggest thing is make sure we either treat with either cooling of the burns using fluids if it's less than 10% or more than 10% body surface area coverage. We'll cover that again in burns. Is dry sterile dressings and keeping the patient warm and preventing hypothermia and infection.
Did I answer your question, Tina?
It did. Thanks.
You're welcome. So cardiogenic shock. Let me see if I can get back. So it's inadequate function of the heart. The major effect is backup of blood. So again, the result in pulmonary fluid is. So some of the things that will happen is the fluid will get backed up in the. It depends on what side of the heart is failing. So if it's on the right side, right, it'll be the. Oh, Kevin, I might be wrong on this. You like this when you'll see the neck veins
JVD.
popping out. Yes, JVD. Thank you. Popping out, and the left side will be like all throughout the body. Because it will, it's the heart's not being able to push the fluid in, and it just kind of just seeps out. Like you see a lot of edema, pedal edema in people for like slow heart failure. Some things like we were talking about, the cardiac tamponade, that's usually caused by trauma, or and the pneumothorax is usually trauma, but like for adult males or late teens who usually are taller and are smoking, they'll have what's called a autopneumothorax. So like their heart just kind of pops. I mean, not their heart, excuse me, their lung pops. And so, but if it's not treated or caught, it will put pressure on the cardiovascular system, and the heart will not be able to pump properly.
And that's because of the backup.
It's just kind of like pushing. Like, so if I have something like you have a not the pericard, the one that goes around the lung. You have a sac around the lung, right?
Mhm.
And that lung pops. It's
The
just going to
pericardium.
fill. Yes, thank you. And it's going to push everything over to this side because all that air is getting in and it's not going to be able to go anywhere. So it's going to push that lung right into the heart, and the heart won't be able to push pump.
But remember that your lungs run on a negative pressure system, so it's going to suck itself in.
Yeah.
Right. And if you have, that would be just a pneumothorax. Then if you start having that tension, getting that heart involved, that mediastinum, you start seeing that, and you start seeing a shift inside. That's when it starts putting tension on the heart. It's just like Morgan was saying with the pericardial tamponade. If you have fluid in the pericardial sac, squeezing that heart, filling up with fluid, the heart can't pump effectively, which is where you're going to start seeing those narrowing pulse pressures, like a blood pressure of like 89/86. Those really close systolic diastolic pressures. That's when you're going to start seeing that, right? And there's nothing we can do in the field to fix that at all, not even as a paramedic. Right, that has to be done in the hospital with a big long needle called a pericardial centesis. They go in with a needle into the pericardium and they pull the fluid out. Right, so there's a lot of things that are going to happen with that cardiogenic shock. So the tension pneumothorax can definitely put a patient into that because that lung is being sucked in towards the mediastinum, the center of the chest, and it'll eventually start causing a shift and putting more pressure on the heart so it can't pump. Right, which is why it's so important in CPR that we don't overbag a patient with ventilations. Because what we're doing is we're putting pressure on the thoracic cavity by inflating the abdominal cavity itself with his stomach. So again, I wish if I was home, I'd bring up an X-ray and show you guys where the stomach's located and the gases that are there, and what happens when you overinflate an esophagus, pushing up against the thoracic cavity in the heart. All right, that's why it's so important that we breathe one breath every 6 to 8 seconds instead of doing it one every 3 on these patients. All right, does that make sense?
Yes.
Right. Is anybody else confused, or is this clear as mud for everybody that's here?
I
Please
feel
feel
like
free
I
to
got a
speak
little
up.
bit of whiplash.
Yeah.
You guys
Got a
want
little bit of
to take
whiplash.
10? You guys want to take 10 minutes?
It doesn't matter.
All right, I just don't want you guys to have the whiplash and then start losing stuff. So
Right.
Morgan and I are both here to help you. So if you have questions now, ask them. All right.
This tag
There's no-
team is great.
And there's no, yeah. I'm doing all this stuff off the top of my head. I don't have any instructor notes. I'm actually driving. So, but just keep this stuff in mind that, Morgan and I are both here together and we're feeding off each other, getting you guys this good information. Because there's a lot of stuff when it starts coming into shock, because that's what a lot of our basis is on. So if you guys need a break, then we'll give you guys the break. We do have 2 lectures tonight, though, where pharmacology is not as in-depth as shock is. So ask the questions, and if you need to take 5 minutes, then take 5 minutes. And
I'll
always
take
remember,
5 minutes.
No. I think if we went through the list of shocks. Now we're going to go through each definition of the shock. I think once we get through those,
Correct.
we can then backtrack to that list of shocks to kind of like bounce them back and forth. Because what's going on now is we got told the shocks, right? But now each slide from this point on is going to tell you in detail of each shock. So I think if we get through
Correct.
that, let's get through this list of shocks, and at that end, but take a break. Because if we stop now, we're going to have to go back to the beginning.
Yeah, I agree. I think we
Right.
were just, it's like a huge dump of information. We just now need to start connecting them to things.
Right.
So I think if Morgan can go through each slide through the definitions of shock, from that list that we saw, it's going to answer some of the questions like the burn victims, where they fall in. We'll probably answer those questions through each slide. Now that we
And
know
I'll throw
the list of them.
And I'll throw some case study stuff at you, like short ones too, kind of put it into assessment perspective.
Okay.
All right.
How about
It's all
we
you.
take 10? No, how about we take 10? Because I got to go get something real quick. And somebody
Oh.
else wanted a break too.
All right, that's fine.
Okay. Just
10 minutes.
because it's been an hour as well. So we'll come back at like 5 after.
Okay.
Morgan, where are our cookies?
The nurses ate them, I think.
Who's Kevin going to talk to while he's driving?
Oh, no, his wife.
I have my wife and daughter with me. We're headed down south right now. No, not that south, but we're headed down to Portsmouth. So
Oh, that must be a really fun drive for them.
No, they're getting educated at least. I brought my
That's
daughter
what
to a
they're listening
CPR
to you.
class in my last EMT class, and my daughter was on the floor doing CPR on a pediatric mannequin, and she was doing really well. She did the head tilt chin lift and everything. It was perfect. She's 7.
I
Oh,
was just gonna ask how old she is.
that's awesome.
We'll talk. She didn't know what to do, she says. She was doing really good though. Yeah, her and I have a lot of medical conversations. She's going to be a good one later on down the road. Maybe go into other medicine other than EMS though.
Other than,
Other than like maybe a physician or something.
well, she might want to become a veterinarian.
Maybe. As long as she can take care of me later, I'm fine. Yeah, this is a lot of information. It really is. And you guys do your reading prior to in your ebooks or if you bought the book itself. There's a lot of stuff in this.
Yeah, I like Kevin bought the book. It really is helping my old brain and eyes out rather than reading on the online.
Tina, I'll bring a book Sunday for you.
I thank you so much. Oh,
Yeah, and you
I'm
can
an
you can
oldie.
do it if you got to highlight, do whatever you want to it, and then we'll just I'll take it back at the end of the class when
Okay,
you're done.
be perfect. Kevin, I noticed that the books that we have online, it expires in September. We actually don't own this book that's on our computer.
Really?
Yeah, it expires September 7th of next
Of
year.
when?
Of next year.
Oh yeah. So you guys purchased the program for 1 year. But I think you still have access to it after. You just won't be able to actually take a class with it.
Okay.
You'd have to contact Jones and Bartlett.
Yeah. Because like, I mean, yeah, I just would want to keep it if that's possible, but there's a lot of
Is there a way you
information.
can? Is there a way you can download it?
No, it won't let you copy it. Won't let you. The only thing we can copy off the book so far that I can figure out is the skill sheets. But
Okay.
Jen is really smart. She can probably figure out how to do all that. She is, yeah.
Quite a bit of time trying to download it and print it, and it's almost impossible because when you can print only so many pages at a time, and it will only print like half of a page if that's the end page, and then when you go to print from that point forward, it actually overlaps a lot of the information. It was hours to just get one chapter. It wasn't worth it.
Wow. All right.
Yeah.
Well, that's good to know for future classes then.
That's how they make their money.
Mm.
So for
What
my
book do-
advanced class, I actually buy the textbooks.
Thank you.
Well, I say that I buy them. The problem is when I order them, they come to me,
Mhm.
and yet I don't see you guys because you're all virtual.
Can't you just have them delivered to the different addresses?
I don't know. I never actually tried that before because I never actually taught it out of state. Normally, I'm in state and people can get it on their first practical day. So that
Oh.
also could be an option. I could have them shipped to JT, who's one of my operations guys for the business, and maybe he can distribute them out to you guys instead of me shipping them from Georgia. So, but again, that's the A class, not this one here.
Is the book by the same company? The
Yes, Jones and
AAOS?
Bartlett. Yep.
Yep.
And for that, we use the 4th edition, which is the newest edition for advanced.
How many people will you have in that class?
Well, I mean, I hope I get 20, but
Oh, okay. So there's plenty of room.
yeah, I can take up to 30 students in the class because it's virtual.
Yep.
So the way I teach my EMT classes is it's kind of like I fill the voids of what people learn. So if they want to jump right into A, they can. and have that background knowledge to be able to help them get through it. The problem is they don't have that real world experience yet.
Right.
So for those people who took their EMT that have been on a fire department and responded to medical calls and helped and assisted and things like that, those are the people I recommend jump right into the A class. There's nothing wrong with that. You've had that exposure. But for those who have not had the exposure at all, you can take it. And if you're a very book studious type person, then yeah, you'll probably pass it. But then you're also considered the advanced life support provider on the truck that you go on to. You'll have an EMT partner, and you're the one that has to make those decisions.
Yeah, Scott and I were
So-
talking about that.
So again, totally up to you. But if you have that background, then jump into it. Take it. The A classes they don't come around very often.
Well, and that was my whole thing with Scott. I was like, I mean, I was a charge nurse. I mean, yeah, it was 8 years ago. So I've got that, but I don't have to sit for the exam right after I take the class. But where it's offered so infrequently, I feel like I want to take it right back to back because it's there. It's,
Right.
and
Were you an LPN or an RN?
LPN.
Okay.
Gabriel.
I was just curious. But yeah, you being an LPN, you really should have no issue at all getting through an advanced EMT class. The question that I have is did you work in the emergency department or did you work on a floor?
I had many jobs. I did a lot of geriatrics, but I also did traumatic brain injury. So
Okay.
I worked at River Ridge and I was a charge nurse there. They
Oh,
looked
nice.
upon LPNs as being pretty significant.
Yes.
A lot of it we learned right there. And, so a lot of trachs, a lot of vents. And because I was trained there, I could do the things that only RNs could do in the hospital, but I could do them there because I was trained there.
Got it.
I always had an RN on my floor, but there was no distinguish, between the RN and the LPN as far as, respect or
So, right. When I worked in the hospital in Wolfboro, we had one LPN that was up from the floor, and he came down and started working in emergency medicine. And he did very well. He did very
Yeah.
well. There were just things that the LPN couldn't do that the nurses could do. Then me as a paramedic, there are things that I could do that
Is
the
everybody
nurses
back?
couldn't do.
Absolutely. There's so much more that a paramedic can do than a nurse, which would cause problems. People would have major attitudes. But see,
But-
when I worked at River Ridge, that was my first interaction with medics. And from the very
It's-
first time they came, I was like, how freaking cool is that? I knew then that that's really what I wanted to be. I
Yeah.
love the whole aspect of the one patient, that's your priority, your partner. Like, I just love that
Yep.
whole interaction.
So, on a side note, I do a lot of ventilator theory classes as well.
Mhm.
So I teach a lot of that to the nursing staff on ventilator theory. But we can talk about it later on offline
Yeah.
and things like that too. So. All right, Morgan, it's all you. Sorry about that.
Don't be sorry.
There you are.
So I guess we'll wrap up with cardiogenic shock. So I have a balloon. That's what I had to go get and find. So this is kind of Starling's law. I don't know if it comes in, but they talk about it right now, so we're going to talk about it. So it's saying that the more contractibility that you have, your heart has, the more blood it will pump. Correct? Right?
Yes.
Right. So once here, let me blow up another balloon. So which one do you think is going to pump more blood, or go the furthest, or have more? The bigger one, or the yes. So the more preload that a heart gets, right, more blood return it has, the more it's going to be able to pump out. Right?
Right.
Makes
Correct.
sense?
Mhm.
That was the balloons, I swear to God. And then
Yeah.
so if anything happens to the balloon or the heart, it's not going to be able to pump blood effectively, right? It's going to be damaged. It's going to be this little balloon. So the cells aren't going to get their nutrients like they need, and lactic acid is going to build up, or just all sorts of nasty stuff starts to happen, and patients start to get shocky. Does that kind of clear it up?
Yep.
So like we'll get into cardiac tamponade and the pneumothorax like later on in trauma and other things that can happen. So just one of the things that can happen is like the heart shuts down. That causes shock for whatever reason. If it's trauma, if it's illness. Oh, I'm gonna move this over. So obstructive shock is caused by a mechanical obstruction that prevents adequate volume from blood filling from the heart to the chamber. So the three common examples is cardiac tamponade, tension pneumo, and pulmonary embolism. I'm kind of confused about the cardiac tamponade myself, but it's still the heart's not gonna be able to pump. So the pulmonary embolism, does everybody know what that is? Pulmonary?
Mhm.
What does pulmonary mean?
Lung.
The lungs.
Lung. Good. Embolism?
It's a clot, isn't it?
Right. So if a clot ends up in the lung, it won't be able to perfuse like the rest of the body because that whole lung or that area will be shut down. It won't be getting oxygenated, or the blood won't be able to get pushed through, so then it starts backing up into the rest of the body. And then that's where the jugular veins come from, or the pedal edema. Right?
And that would be the left side?
It could be left or right.
Okay.
Because like it depends on where the thrombosis happens.
But
If
it's the
it's-
left side of the heart that would cause that situation.
Right.
You would
It
say,
won't be
okay.
able to. It won't be able to get into the. Well, it could be on the right side because the pulmonary artery goes out, and it could be blocking that part of the heart from the blood getting into the lung first, and then that could be the left. It'll just reduce the stroke volume of the heart, and that's when we start getting third spacing and edema.
That makes sense.
So the other
So-
name for third spacing, just you guys, Morgan, he's bringing that out. That's more of our paramedic or EMS slang term for it. It's called interstitial fluid. You might see that more in a textbook.
Yes. That's with fluid that's outside of the cells, not where it's supposed to be.
Correct.
Or the vascular. So cardiac tamponade, like it's a collection of fluid between the pericardial sac and the myocardium. Becomes large enough to prevent ventricles from filling with blood. It's usually caused by blunt or penetrating trauma. So it can be caused by penetrating trauma. Like if somebody gets stabbed and it just barely nicks the heart or whatever, it can start bleeding. The signs and symptoms are referred as Beck's triad. Does anybody remember? Did anybody write it down, take notes? What's Beck's triad?
The narrowing of the pulse pressure, JBD, and muffled heart tones.
Yes. So the tension pneumothorax is caused by damage to the lung tissue. Air is held within the lung, escapes in the chest cavity, and the lung collapses, and the air supply pressure to the organs, include the heart and great vessels. You can like actually look these up on YouTube. Yeah, I'm sure there's good videos. I don't have any, and so like we were saying before, like just the air's negative pressure coming in, and then so won't be able to get out, and it just pushes that lung over, and it won't be able to, the heart won't be able to function properly. A pulmonary embolism, a blood clot that blocks the flow of blood through the pulmonary vessels. It can result in complete blackup of blood in the right ventricles. So yeah, that's when it's getting, so the right ventricle goes to the right, not the right, the right ventricle goes to the pulmonary artery. And so if it gets blocked in there, then it just starts, the blood just won't be able to pass through at all. So distributive
Can you
shock.
guys, can you guys give me some examples of how a pulmonary embolus would happen? Or what's a common cause of a pulmonary embolus?
Oh, I just thought it's like,
I'm gonna take a wild guess.
So-
I'm gonna say steering wheels.
Okay, so we'll say trauma. How about trauma?
Okay.
Okay. What about long flights, long drives, patients that sit for long periods of time? Can that cause a pulmonary embolus?
Mm-hmm.
Yeah,
DVT.
DVTs.
Yeah.
Through a deep vein thrombosis, exactly. Right. Another thing that can cause that as well is deliveries. The mom delivers a baby.
Hmm.
Okay, that can cause a pulmonary embolus, causing a blood clot to free up. Other things that you can see it with is obviously trauma. So think about the different aspects of what causes that pulmonary embolus, right? And one of the cool things about pulmonary emboluses as well, and something you can do for monitoring for that, right, is end tidal monitoring. So if you have a patient who's complaining of, let's say leg pain, and they have chest pain, they've had syncopal episodes, you know, almost like that, the whole panic attack, looks like a panic attack, throw them on some end tidal as well. One of the things you'll see is a normal end tidal, and if a clot frees up and goes somewhere else into the lungs, you'll actually see a decrease in end tidal CO2 down to about 18 or so from the normal 35 to 45. That's also one of the indicators you'll see for a pulmonary embolus. Right. So there's other tools that we have, and also assessment techniques to be able to pick up on a PE in the field. But the true diagnosis is not blood work. Okay, D-dimers are completely useless, right? But the true indicator is what they call a CT angiogram or a CAT scan angiogram of the chest. Patients that have symptoms of PE need to get to the hospital right away. They need to get a CT done, and they're going to go to a pulmonary surgeon to get out there and remove the clot. We're also going to be started on a lot of heparin as well. So just kind of keep that stuff in mind. Now I told you the course of treatment as an EMT, recognize it and get them to the hospital as quick as you can. All right. And monitor vitals.
Yep. Breath control too.
Yep, another one. That's why a lot of them take aspirin.
So now we're going to talk about distributive shock. Does anybody remember what that entails for distributive shock?
Well, it's gotta have to do with how it's being distributed throughout the body.
Right. Remember, that's the 2-inch hose into a 4-inch hose. We only have what, 8? Oh my God, how much blood does a human hold? An adult male?
6 liters.
6 liters. And so if our all of our vascular system just all of a sudden opens up, it's not going to be able to pump that through effectively. The circulating blood volume pools and expands. So that's when you see a lot of people with trauma, spinal trauma, like some of their body is more than perfused and the rest of the body is pale and shocky looking.
Yeah, below the
because
injury.
right. So septic shock is usually it's caused by infection that's not really treated yet. And the body just kind of it releases what's called mast cells, and like globally, and so they just get really sick, and all their vascular just opens up, and their heart rate just skyrockets, and their blood pressure can either go down or up, right, Kevin? He's not. So
No, I'm here.
and then
The blood pressures will be normal to
okay.
start, but sorry, I was eating my dinner.
Oh, sorry.
And driving
fine.
and teaching.
I'm doing
Right.
all this. It's crazy. So
Multitask.
Have
what
your
you're gonna
daughter
see is-
drive.
you probably would.
I tried when I was little.
So here's the thing. Septic shock is a whole, like I said, a whole different ball game. We're leaking stuff out where it doesn't need to be leaking out, right? Pressures are going to start dropping. We're going to start seeing some other changes. Here are some of the indicators. You have to have something called SIRS, systemic inflammatory response syndrome. You have to have 2 or more of the following, right?
Fever.
A heart rate of greater than 90, an end tidal less than 32, a respiratory rate of greater than 22, a temperature of greater than 100.6 or less than 96.8 degrees Fahrenheit. You can have something called cold sepsis, which is very dangerous. Right? That means your thermoregulators are no longer working appropriately. Right? Blood glucose used to be part of that. It's not. It took that away because diabetics and everything else, it was hard to get adjustments on there. Right? Altered mental status and a MAP of less than 64. 2 or more of those, all right, with a known or presumed infection site is called sepsis. All right. Severe sepsis, all right, is when you start getting hypotension and you give fluids and you can get the pressures back up again. If you've given 2, 3, 4, 5 liters of fluid with no changes and the patient is still hypotensive and altered, now they go into septic shock, right? And this is where we have to start filling the pump. We got to prime. This is more for like what Morgan and I would do, is we need to make sure we give the fluids first to fill that system, to prime that pump. Then we can give our pressors. And the pressor of choice for sepsis is Levothyroxine, right? Norepinephrine, because of its alpha effects, right? That's what we look for. That's a Morgan and I thing, right? So there's different processes behind it, but sepsis is one of the things that is really misdiagnosed in the field because you don't pick up on those slight indicators. A patient has a heart rate of 110 with an end tidal of 28. The patient's alert and oriented with a fever. People are like, oh, it's not sepsis. He's fine. No, it is. The patient is still septic and he still needs to be treated. We just caught it early enough. You know, and what do you think the leading cause of sepsis would be? Leading cause of sepsis. Right? Hold on.
A cat.
Hospital-acquired pneumonia is one of the leading causes of sepsis. Now, Morgan mentioned UTI, and that's also another one too. But that's what we call urosepsis, uroseptic, because it's in urology.
Well, I don't go to the hospital.
Right. And UTIs can happen anywhere. More prominent in females and males due to the urethra length. Okay, that's why females get UTIs more than males do. Right, males still get them, especially if they're uncircumcised, because the infection can build the infection, everything else, and crud that builds up. Right, so you got different things, and you got to ask these specific questions. That's why I said don't be afraid to ask the important stuff because we need to know.
What about C. diff?
So,
that's not septic.
That's different. Without getting into detail about how staining works and all that kind of stuff, right? C. diff is not really going to cause the sepsis, all right? And the only way to cure C. diff is by feeding somebody else's feces into the patient.
Okay, moving on.
It's a fecal thing, right? So I'm just.
But you can
guys
go into
asked about C. diff, I'll
septicemia
tell
with
you how
it.
it works. You potentially could, depending if the infection got somewhere. If there's actually an infection, though.
Well, I mean, it. My mother passed away from C. diff. I mean,
Right.
it took her life. I mean, she went septic.
and it can
Oh,
get
wow.
down to that road. I just haven't seen as much sepsis with C. diff as I have with pneumonia, UTIs,
Yeah.
Bowel obstructions. I just had a septic patient the other day I picked up. Patient was in septic shock by the time he got to the hospital. I'd already given the fluids. I wasn't going to pressors yet. We were 10 minutes down the road. Right. So we picked up on that. We picked up on all the indicators. Patient was admitted to the ICU. So again, sepsis is very dear to me because it's one of those things looking at CQI on a clinical standpoint. A lot of providers from EMT to paramedic miss it. They miss those indicators. Sepsis and bacteremia, all right, turns into MODS, multiple organ dysfunction syndrome, okay, MODS. That means that our organs are starting to fail. What else can happen with that?
Well,
Um,
I actually had a blocked intestine that I let go unknowingly, probably for 2 weeks too long, and I was admitted to the emergency room, and they thought it was my appendix because it was in the same, like the pain was in the same area, and before they cut me open, they did a CAT scan, and they realized that I had a blocked intestine and I was septic, and I was in the hospital for 4 days. Tube down my throat, my nose, sucking everything out. It was gross.
Yeah. So the other thing that happens with patients that are in septic shock more long term with it in the hospitals and not picked up on is something called DIC, right? So DIC is disseminated in intravascular coagulation. So basically, they're hypocoagulating. So a ton of blood clots, lots and lots and lots of clots, causing people to lose limbs and everything else. That's more late stages of septic shock, right? So again, EMT level, Morgan's talking about this a lot. Toxins that damage vessel walls causing increased cellular permeability, right? We're losing fluid, organs are shutting down, right? Hypocoagulation, so hypercoagulation, right? Death, losing of limbs, all because of a simple hospital acquired pneumonia that didn't get treated right away. As simple as a UTI getting into the system for uroseptic, right? C. diff, we just talked about that, right? Infection from a wound. Right. So I just wanted to kind of make a mention of that septic shock. I do a whole lecture on this. And literally it's like 2 to 3 hours of just talking about sepsis because there's so much behind it and we miss it so often. So read up on it, learn it. Morgan, you're doing a great job with it. I appreciate all the help you're doing here. And
Thank you.
yeah, just keep going with it, man. I just wanted to
Okay.
get my tidbits of sepsis.
No, I've learned quite a lot too. So something like he touched on as well, the cells, because they dilate, right? Like when they're contract, they're pretty like, oh my hair, pretty small. But as they're opening up, they become permeable, right? So what would happen if
Things
hoses
leak.
they leak? So fluid gets, oh, I'm horrible. I'm on my laptop, so they're not able to contract. They're not moving fluid, and I don't know how to get rid of that now. So they're not moving fluid, and it's leaking out. So, like Kevin said, interstitial spatial third spacing. It's not where it's supposed to be. I don't know how to get rid of that.
Just go to the next page,
Oh, well, perfect.
right? There you
Yep.
go.
Good. So yeah, widespread dilation combination with plasma loss through the vessel walls results in shock. It's kind of like hypovolemia. I mean, but it's not the lack of fluid. It's because the vessels are just not constricted, and so there's just a loss of fluid. And there's different ways. Like if you went down the road for more, like we would correct this with norepinephrine and fluid, and you just get them to the hospital. I don't know. So neurogenic shock is another type of yeah, it's shock. This causes distributive. I just mentioned it before. Somebody who has a spinal cord injury, their vascular below can't respond to the autonomic nervous system, so that just all kind of opens up, and then fluid leaks down and pulls into the. But like above the injury site, it's perfectly fine. Like it's pink, and it's perfusing appropriately. So what's something you guys can do for neurogenic shock for somebody who has a spinal cord injury?
Keep them warm.
Yes, keep them warm. Anything else?
Find stabilization.
Yes, you're definitely going to do. But if they're on a board, you can raise their feet.
Oh, the Trendelenburg. Yep.
Right. Just keep in line the spine. But that does work. I'm a huge fan. Like again, sometimes advanced providers forget the basics, and sometimes the basics works very well. Anaphylaxis again is. Any questions about the neurogenic shock? Yes, no, I can't.
Are there any other causes, or is that really a spinal cord injury?
That's more of a spinal cord injury because there's just a certain point. I guess if there are other issues that from the nerves, like I that would cause the vasculature to open up.
Yeah.
I'm sure that would be something else. So anaphylactic. What can somebody tell me? Anybody here have any allergies? I should have asked that before I brought in cookies because that could have been interesting. We would have had a great lesson. So what happens with anaphylaxis?
So like a nut allergy there, where your throat closes, you can't get enough, can't get enough air.
Right. That's part of it.
Yeah, mine's clams, but I grew up eating them, and it only came on as an onset as an adult.
Oh, did it?
Yeah.
So yeah, your airway, like your entire airway kind of shuts down, like constricts. Your body's just kind of exaggerating the response. So like your airway shuts down, clamps up, and your bronchioles will too. And then your vascular system will just dilate again. And again, third spacing happens, or the interstitial fluids. So yeah, they kind of go into anaphylaxis a little bit. So like somebody like my son had allergies a lot as a kid. He still's allergic to like pumpkin and squash, right? Devin? Squash. He's allergic to a couple of things, but if he keeps he will break out from head to toe if he eats like pumpkin. But if he kept going eating that thing, he could like build like a more severe reaction to it, and then he could end up with anaphylaxis. Like he used to break out. Like we had to take him to a allergy specialist in Dartmouth, and it ended up being one of the things he was allergic to was dust mites, and we had a rug, so he'd like break out randomly. But after we figured that out, it was like every time we vacuumed, he would just break out. But so that's not exaggerated. That's not anaphylaxis. That's just an allergic reaction. Anaphylaxis is like the extreme exaggeration where the upper airway closes, the bronchioles close, and it's our job to like open. Like that's one of the things that you guys can give is epinephrine, which constricts the airway. And when you become A's, you can give albuterol, which opens up the bronchioles in the larynx. So some of the this chart just gives some of the symptoms for anaphylaxis. flushed, itchy, burning eyes, urticaria, edema. Like, so that's one of the things too, is like their lips and mouth will start swelling up because of the third spacing. Like fluid just starts seeping out of the vessels. Excuse me. Dilated peripheral vessel. Sneezing, itching. So this is all kind of like both anaphylaxis and regular allergies. But you just think of allergies, but extremely in an extreme condition. Any questions about distributive shock? So that's when the vessels just kind of aren't able to work the way they're supposed to. Right? That's the into a 4-inch hose. It's just not going to be effective. Oh, another psychogenic shock. So that's the one with bad news. And it's kind of like the neurologic shock. People just faint. And I'm going to see if I can find the video on the next break. Like I have one where a woman is on a ride. I think it's like the slingshot. Do you know what that is? I think it's out in Vegas where they pull him back and let him go. You see her, she just kind of passes out. Then
Yep.
she comes to and passes
Yeah,
out
see
again.
it.
Yeah. So that's
Yeah.
like psychogenic shock.
Yeah.
Or when somebody, like you start an IV on people or give them shots and like, oh, I don't like needles, and they end up passing out. And that's their vascular system just dilates because of the over exaggeration of the response.
Morgan, the distributive shock, you mentioned it's, 2-inch to a 4-inch. Can it also be distributive shock if it's going from a 4-inch to a 2-inch? Or is that back to the pump issue?
That would be back to the
Or does that just not ever happen in shock? Is that just something
it
completely
does.
different?
It's obstructive. That would be kind of considered
That'd be-
obstructive,
Obstructive?
right? Because that's when like we have that thrombosis.
Oh, yep, okay. But the thrombosis is actually
Well, that's when you're like clotting something off or something is like
right.
the blood's not passing through. So
But
like
if your vessels are actually shutting down or closing up, is that part of shock or not?
not really.
Okay.
I mean, the body's gonna when it starts going into shock, it's gonna, unless it's distributive, it's gonna try to compensate by shunting and shutting some pathways down.
Mhm.
What it's supposed to do, but when it becomes irreversible shock, which I'm sure it will get into, is when everything just kind of opens up again because it just can't keep up. So it just kind of gives up and opens up, and then we're behind the 8 ball. And right, Kevin? Oh, he's gone. So yeah, hypovolemic shock is when it's not an adequate amount of fluid or in the body. Like and it can be caused by electrolyte imbalance. Like elderly or babies are really prone for that. I had a woman who had a really, really bad period a few months ago, and she was messed up, and we treated her with fluid. And I don't know if she got a type and cross in the ER or not, but it can happen. So the thermal burns right there for Tina can cause hypovolemia shock. And so an example I had sticks out to me a while ago for hypovolemia, besides the woman with a period, which was really interesting, is I had a guy who had a lower GI bleed. Do you guys know what that is? Okay, for the you're bleeding into your gut somewhere, and it's coming out of your butt, your rectum, and it's usually like black and tarry or coffee groundish sometimes. But he's had this for a couple days, and he had a commode right next to him full of blood. Like he told us after, and we moved him to a stair chair, and as soon as we moved him, like he passed out. Like he went pale. I thought he was dead. Like the fire department was there, but we couldn't get him out any other way than the stair chair, so we just hustled. And as soon as we got him on the stretcher, like I put him right in Trendelenburg's because that was like it's easy, it's there, and like he kind of came to after that. And I gave him fluid, of course. So any questions about distributive shock, hypovolemia? So that's when, like, if you do have a 2-inch hose, but your tanker ain't there yet and you're losing water, it's not going to work very well. Good analogy? Right. You're not going to get much water on that fire. So there's stages of shock. So compensated shock is like the early stages when we're kind of compensating it for it. Like the woman with a period, she was compensating. She was definitely shocky. She was pale. Again, your heart rate goes up, your respiration rate goes up because you're trying to blow off the CO2 that's building up. Your pressure's kind of going up because it's trying to if it's lacking fluid or blood, it's trying to get it back up there to get it, because we were trying to compensate for that pre-fill, right?
Yeah.
Right. Decompensated shock is late stage, when the blood pressure is starting to fall. Like Kevin said with the septic shock, like it goes up, and then when it starts coming back down again, you got to start intervening. There's no way to. So then there's compensated shock, decompensated shock. That's when they start going backwards, right? And then irreversible shock. That means whatever damage is done, it's no coming back, and they usually end up dying. So we must recognize, like you guys recognize and treat shock early, like, and you do. And again, like I have more tools in my toolbox, like of norepinephrine fluids or whatever, but the basics are what save lives. I don't know if it talks about it in here, but there's a triangle of death. So it's pH, being cold, and I think blood loss is the other one. So like you guys can fix 2 of the 3, or you can like move blood around, like with the Trendelenburg. So you guys can do a whole lot with recognizing shock and treating for it, like making sure there's a blanket on the patient, like making sure the heat is all the way up.
But we can always be checking those vitals so that we're catching it from the compensated shock to the decomp.
Absolutely. And you can always that's why we check every 5 minutes, to just keep cycling.
So that you can play with your toys and.
Right. And just, when was it? We had a patient in Errol, and I can't remember what it was for, but like one of the first things I did when I walked through the door was like, they like to run with their windows open, but I like shut all the windows and crank the heat up. And I can't remember what the call was, but after they're like, oh, that was a really good idea. So here's some of the signs and symptoms of, and I've seen all of these. So agitation, anxiety, like they're going to be anxious because they're thinking they're going to die. They're got that fight or flight going on, which is just adding to it. If they say that they feel like they're going to die, they're probably right. Well, you want to get it going. You want to treat whatever you can. You don't want to be behind that 8 ball. They will say, I feel like I'm going to die. Or like one of, like now makes a lot of sense, is I feel thirsty. Like I need a drink of water. And that's probably from third spacing, or like Kevin was saying, it takes away from their digestive system. Cap refill longer than 2 seconds in children. Marked thirst, narrowing pulse pressure. That's a lot for neurologic and cardiac. then so when we become in decompensated shock, our blood pressure starts falling. So when we talked about the 660 a map, and Scott said it's like 50 now, right? Remember the 50 and the 60? The systolic plus diastolic divided by 3. In trauma, they want, they
Sorry.
want, oh, don't be sorry. They want,
Well, can I stop you for a second?
sure.
So as far as like the test taking, I noticed a lot of the questions when it came to this particular area of the test, when it would say signs and symptoms, and then, or it would say, what are the symptoms of, let's say, compensated shock? You have to remember what a sign is, and what it'll, all of these, and you'll have to list out what the symptom is, not the sign. So even as simple as the signs and symptoms, that's how they'll screw around with you on that test. They'll be like, oh, what are the symptoms of compensated shock? But they'll give you the signs,
Oh,
like one symptom.
Yeah.
And you're thinking, oh, it's got to be.
so between the
a lot
subjective and the
on the
objective.
test, just a FYI.
Oh, okay, that's really good. I didn't take any of the. I should look at those.
Remember, symptoms are what the patient tells you. Signs are what you can see.
Yeah.
Subjective and objective.
Like I feel like I'm gonna die. It would be a sign. Pale skin would be a symptom. So decompensated shock is the falling blood pressure, declining mental status. If all of a sudden they pass out, that's not a good thing. Or if they are alert, like if they're talking to you and then all of a sudden they're not. Or they become agitated too, and then they just increasingly get agitated even more and more. Dilated pupils is not a good thing. And even though like poor urinary output, that's something like, especially in critical care and ICU stuff, they pay a lot of attention to the output of urine, especially ins and outs. Like if we put 4 liters in, they're going to want 4 liters out. Any questions about progression of shock? Any questions about progression? No. Yes.
No, I don't think so.
No. So your heart rate's going to get up, their agitation, blood pressure is going to go up. You could be flush, you could be diaphoretic, but then all of a sudden your blood pressure is going to start falling. Then you're just going to start going downhill. So yeah, the blood pressure, and this will probably be on the test. So the blood pressure may be the last measurable factor in the change in shock. It will be for kids. Just it's gonna, especially people with if somebody's in trauma or in shock, look at their meds, and like Kevin was saying, and I'm sure we'll take a look at it the next one. If a patient is on beta blockers, that will mess with you and everything else. So just make sure. Yeah, when the blood pressure drops in infants and children in shock, they're close to death. There will be dead. Like kids will compensate, and then they're just dead.
So you're where you're saying maybe the last measurable factor. So you may not have had a blood pressure that was indicative of shock per se, and then all of a
Right.
sudden you're saying it can plummet or change dramatically.
It could go up, and they could be in shock, you not know it. Like their respiration is going to be one of the first things to change, and then we should actually be counting. Their heart rate will go up, and then whatever factors, then their blood pressure will change.
Okay.
So we'll cover. I don't want to get pediatrics as its own special lecture.
Oh my God.
So I don't want Morgan getting too in detail on peds right yet, because there's a lot of different things to look for. But if you want to look it up, look up the PAT. So it's called a pediatric assessment triangle. All right, and that'll help determine whether or not it's respiratory, circulatory, and things like that. I just don't want we're going to get too in detail this during the shock lecture in peds, because like I said, pediatrics will probably spend an entire just one 4-hour block just covering peds.
Kids are scary. So yeah, expect shock for a patient is any one of the following: multiple severe fractures. So like a pelvic, we talked about a pelvic fracture the other day. They can lose a lot of blood. Femur fractures can lose a lot of blood. Like thoracic, like abdominal injuries, you could lose a lot of blood in your abdomen as well. Spinal injuries, we talked about the priapism, and that's one of the reasons why people get priapisms, is because the vasculature in the penis area like dilates, and it's that kind of tissue. Severe infection, major heart attack will cause cardiogenic shock and anaphylaxis. So we're gonna do a scene size up. Anybody want to walk me through if we're gonna do a trauma assessment? Because we did that Sunday. What's the first thing we do when we get on scene for any call?
Okay, scene safety.
Scene safety.
BSI.
And
Yes,
thank you. BSI, scene safe. So what are we looking for when we just do our scene size up?
A patient.
What's that?
MOI.
MOI,
NOI.
safety
Other
hazards,
contributing factors.
how many patients we have, we need more personnel, the way of egress. So scene size up, be alert for potential hazards, use gloves and eye protection. Yes, we should be using eye protection more than we do.
Do you wear face masks or do you do goggles? Like, what do people do that are wearing glasses?
Injury.
We have safety glasses. Nobody really uses them. We
But
should.
what would you do in my case? Like, I have to wear glasses.
You can get safety shields.
Yeah, so I could wear
They
like a
have-
face shield.
Yeah, or we have face shields too.
Yeah.
It's one of the things that were required on ambulances. So the mechanism of injury, like if it's a ATV accident or vehicle accident or whatever, like depending on what caused the injury, we'll be starting to look for in our mind of what injuries we're going to be looking for. And the nature of illness, same thing. If somebody's like having a heart attack, we're going to be kind of focusing on that. So what's our primary assessment? What's after the scene size up? I just said it.
Or ABCs.
We're going to make a general,
General impression.
right?
Yes.
What's a general impression consist of?
Your primary. Yep.
What we need.
General. It's like general.
Poor.
Is he breathing? Is he conscious? Is he?
Sick or
Like our
not sick?
ABCs.
Oh,
Oh,
sick or not sick. That's right.
Duh.
Or we're going to stay and play? Or we're going to get out of there?
Load and go.
Right. So then we're going to do our primary assessment.
Our ABCs.
Our ABCs. We're going to look for something, what's wrong with the patient that's going to quickly kill him, and we're going to correct it. Like if somebody's grossly bleeding, we're going to tourniquet, pack it, stop it. And then like if they're breathing, if their airways, if their tongue's rolled back, or if they have something in their mouth, they have dentures, like if anybody's unresponsive and I find out they have dentures, or if I have to do anything with their airway, their dentures are coming out. As much as I love dentures. And then we're going to determine their level of consciousness. We're going to have our partner take C-spine right off the bat.
And place appropriate cervical collar.
Good job. We're going to, right off the bat, we're going to apply cervical collar for a trauma if it's something. identify and manage life-threatening ABCs, determine the patient prior to patient ABCD, determinant, and E, expose. So this is provide high flow oxygen to assist in perfusion. Kevin, what do you want to weigh in on this? It might help. It won't hurt for a long term until you can get a better grasp of what's going
You
on.
went
And
into a
how
bridge.
perfusion legs. What's that? So provide high flow oxygen.
Doesn't it help though? Because it will adhere to the red blood cells so that,
It will.
I mean, they might be losing some blood, but
Yeah, but we don't want to do
So-
free radicals. And here, Kevin's
Right.
brain in.
Yeah, so it's more of you got to treat your patient, not the numbers that you see. We want to make sure we have our pulse oximetry reading, however, between 94 and 99%. Once we start seeing that 100, now we can't measure anything higher. So now we're really flooding the vasculature with oxygen. That becomes free radical, which then in turn changes the oxygen dissociation curve, right? So a lot of big terminology, big things. Too much oxygen, not good for the body. Over oxygenated cells, things start to die, and we don't want that to happen. Our body has to function on oxygen, nitrogen, argon, and all the other ones. Those are the three biggest ones: are oxygen, nitrogen, and then argon is a very small number. Then it goes down into the decimals below that, and what takes up the normal atmospheric air that we breathe in, right? So we want to make sure that we're looking at what we're administering. So if we have a patient who's pale and diaphoretic, and have that shock like look, then yeah, they need oxygen at that point in time. But again, if they're bleeding out, what is oxygen going to do if they have nothing to attach to, right? So look for your oxygenation based upon what the patient needs, right? Remember, there's oxygenation, perfusion, but there's also ventilation. So are they oxygenating fine but not ventilating fine? Do we need to use a BVM with oxygen instead to help fix that drive, that rate? So there's a lot of different aspects that we look into, and not just giving someone a high flow non-rebreather, right? We're not trying to do nitrogen washout. This is not an RSI type thing we're trying to do, right? It's only good for patients that are going to be intubated with paralytics and sedatives. Other than that, we don't want to go down that road, right? So, I mean, I don't want to get too much in detail on the dissociation curve of oxygen because I'm going to confuse all of you. So I'd rather not get
Just
into
give
that
a little.
point of it.
And
but
then
if
see how
it's
they're
on the
doing.
test, I mean, because everywhere it always says provide high flow oxygen, and then we're
It
learning that
does.
free radicals, but nowhere in the book is it talking about free radicals.
And
So,
it's probably not. That's something you're going to get at the advanced level and higher.
so
So
as a
so
test
like I
question,
mentioned, as a test question, okay, provide high flow to via non-rebreather. I told you guys to be in the class. I'm going to teach you what the National Registry needs you to know to pass the test. But I also want you guys to be clinicians and learn what you're doing as well. So there's the real world, and there's what these paramedics sit behind a desk ready to test for. Right? So treat your patient, not the monitor. That's the biggest thing. Don't treat the machine. Treat what you see in front of you. Right? You got a patient, like I said, who's pale, clammy, and diaphoretic with trauma. Yeah, they need to be kept warm. We got to increase their volume in their system if needed. Baseline set of vital signs, secondary set every 5 minutes, and therefore looking at your trending. Put on end tidal. Every trauma patient gets end tidal CO2. We're going to measure perfusion. We're going to measure oxygenation, and we're going to measure ventilation. Right? Inspiration, expiration. Are we getting enough tidal volume? Are we moving air? Right? That's the things that we're looking for, right? So all those things together provide that homeostasis that you need. So there's what you're going to do to pass the test. Yes, high flow oxygen, as I said, provide high flow to via non-rebreather to assist in perfusion, right? But how is the patient perfusing? Okay, skin color.
That's if there's
temperature.
inadequate breathing.
What was that?
So Kevin, so if there's inadequate breathing, we're gonna say to the, if we're doing a practical, we're gonna say we're gonna provide high flow oxygen to assist the confusion. If there's inadequate breathing, but if the breathing isn't inadequate or in
Well, I don't want you to
Um,
get confused. I don't want you, Fred. I don't want you to get confused though. Okay. Is the patient inadequately breathing, or are they deoxygenating? There's a difference between the two, right? If they're breathing inadequately, too slow, too fast, irregular, then we have to use a BVM. We're not just going to put it on a breather on. If they're deoxygenating but breathing normally, now it's a non-rebreather. Does that make sense?
right.
Right. You have to differentiate the difference between
Yep.
inadequate
Nope.
breathing versus oxygen. Yeah. Because that's what's going to get people is they're going to look at, oh, well, let's just put them on a breather. It's perfectly fine. And it's not. If they're breathing
Okay.
45 times a minute, right?
Yeah.
Our end tidal is going to be low because the faster we breathe, the lower the end tidal, the lower the carbon dioxide coming out. Now we're starting to retain, and we're starting to off gas too much, not retain, but off gas too much, right? And that's going to cause our shift. We got to bring that back. So we got to control the breathing, right? If we're breathing too slow, our end tidal is going to be high, 55, 60, big waveform, right? Again, all EMT stuff I'm talking about. So we have to bring the rates back up again to meet that. We don't base things off of end tidal is very accurate, okay, as long as you have the right devices in place. So we don't look at just oxygenation anymore. We don't look at just ventilatory status. We look at off gassing too, perfusion status as well. And all that plays into key. But then you have to look at the underlying cause. Why is this happening? Why is the body treating that mechanism? Okay. And there's things I'm not even going to get into. We're not going to talk about that part. Why is it happening? Is hypovolemia causing that to happen? Is there a shock-like state causing this effect? And unless you fix that shock-like state, we're still going to get that effect because your body triggers that mechanism, right? And it's all done through the medulla and everything else that I remember Morgan talking about before, trying to fix that hypoxic drive, right? And that's how we're going to fix it, is by ventilating for them and stopping the problem and fixing it. So there's a big picture behind everything that Morgan's looking at, not just saying, I know this is kind of off, but it all makes sense at the end. Cause and effect, cause and effect, and cause and effect. This is the effect of this cause. How do we fix that cause right now? Patient's bleeding out, we tourniquet, we pack it like Morgan said, and we move forward. We stop that bleed. But they still lost that blood. So you need ALS coming to replenish that volume that was gone, right? Before we start having pump issues, vasculature issues, okay? Going into that shock and starting to see that peripheral constriction to save the core, right? So yes, we have all the ventilatory issues. We need to fix that, but the underlying cause really is hypovolemia. So cause and effect of what we do and what we see. Did that answer your question, Fred? I hope I didn't step on your toes of that. I just wanted to kind of clarify the difference. Sorry, I know that was a lot.
Does that answer your question, Fred?
Oh yeah. Yep.
Yep. Jason, you have any questions about it?
No.
I'm just reading the book about end tidal. I wanted to read it again.
Okay. Jen, you
Do
all
those
set?
do those machines that you guys had on the bench the other day? Does that
Yeah.
give you an end tidal number?
Yes.
All right, because I was wondering. I'm looking at the little nasal cannula, and I'm like, how do you get that thing on? You know, like, so yeah. So your machine will read that. All right.
Yep. Jen, you have any questions about it, or Tina?
No, I think I'm
No.
okay. I'm just gonna put my
No.
neck brace on and
Very
control
good.
my whiplash.
Yeah.
I know it's a lot.
It's
Colin,
okay. It's all good.
Nope, I'm good. Yep.
You're good.
Maybe
But to
sometime we
answer
could
the end all,
check out that machine.
Sure.
but to answer the end all question for the testing purposes, going way
High flow.
back to what we just talked about, high flow oxygen, non-rebreather, put it on the patient.
Okay.
Right. We'll talk about clinician stuff afterwards.
And once you guys start going out and do your ride-alongs, and you're gonna be able to put one together, so the whiplash won't be as severe, because
Be a
you'll
different
start
kind of whiplash.
seeing the terminology working.
Good to know.
I can't
Right.
wait.
So we will be providing high flow oxygen on the test, but in real life for clinicians. For hypoperfusion, treat aggressively and provide rapid diesel. So you guys can treat hypoperfusion, like keep them warm and position. And request advanced life support. And that it's on, you can always ask for DART or main med or wherever you're from. So this is really not in order. Former general impression, assess the airway to make sure it's patent, because we look for, like, maybe they have food, maybe they were chewing gum, maybe they have dentures, maybe they have a bridge. Like, we want to get that stuff out of there so we don't cause another issue. And then assess breathing. Are they breathing too slow? Are they breathing too fast? Are they just, is it too shallow? Is it too labored? And then again, like we were talking, I think I was talking to Tina about it. We control what we want them to do. If they're breathing too fast, we breathe for them. If they're breathing too slow, we breathe for them. Increased respiratory rate is often an early sign of impending shock. And assess the patient's circular status. What are ways we can do that? Assess the circulatory status. Pulses.
On the peripheral.
Right, in the central, we can. Is it
Capillary
rapid? Is it
refill.
cap refill? What's the largest organ? One of the ones that will show
The skin.
Skin.
skin
Diaphoretic,
color.
cool,
Yeah,
clammy.
clammy.
Would they be showing any altered?
They could be. Usually, they start becoming agitated.
Yeah.
Like, they know something's wrong. Their body's pumping adrenaline into them. And they'll become agitated. Or they'll say, I think I'm going to die. Like, huh. In shock or compensated shock, the skin may be cool, clammy, or ashen. So it won't really say, and I'm sure that's going to show up again for you. It could be compensated or decompensated for cool, clammy, or ashen.
Yeah, I think the
Assessment.
cyanosis is when they are actually blue, that's when it blows it into the decompensated. I think that's what I read.
Probably. That's more respiratory with, like, the blue, the cyanosis. But I guess it could, yeah, because of the more CO, so it'd be, and this is like just the blood. The tank is not full or is not pumping pumping properly. And we need to identify life-threatening bleeding and treat it at once, like the tourniquets, packing,
Bandages. Never remove them.
Don't ever remove them. Determine if high priority, like that's D. Do we need to get them to a hospital, or should we wait and do what we can for them? Trauma patients with shock or suspicious MOI generally should go to a trauma center. So, yeah, DART or main med for us up here. But if you're in a larger area, like the closest appropriate facility, that's gonna be a test question over and over again. Closest appropriate facility. History taking, again, determine the chief complaint. Like, if they're shocked, what's causing the shock? Obtain a sample history. What are ways we can do that? Even if they're, like, altered, what are ways we can do?
Oh, you can ask questions if there's people around.
Bystanders.
Medical bracelet.
Yeah, medical
Medical
bracelets.
bracelets, good.
Check their
Wallets.
medications.
Check their medications.
If they're there, yeah.
So secondary assessment, repeat the primary assessment followed by a focused assessment. Focus assessment is like if they are alert and oriented, and they say I bumped my arm and it really hurts, and there's like nothing else wrong with them really. That's a focus assessment. Huh? Excuse me?
Then you focus on that arm.
Right.
Right.
But if they are altered, or if there is trauma, or if there's something, we want to do a detailed physical exam. A rapid
Morgan?
then a deep. Yes, ma'am.
Where are we doing the head to toe assessment?
So they don't have it in here,
No,
DCAP.
that's,
but it would be in your
I've yet to see
secondary
DCAP.
assessment.
would it be at the beginning or are we doing vitals first?
It's all encompassing.
Okay.
You can
If,
have
oh
a
yeah, if
partner.
there's two of you, someone can be doing vitals while the other.
If there's a trauma, there are going to be plenty of people there.
So your rapid trauma assessment is during your identification of light threats. That's your
Right.
head to toe, 60 to 90 seconds. Then you get your vital signs, you get your sample history and all that. Then you move into your detailed assessment again, which is head to toe. But then you go in detail at touching every rib, orbits, start from the head down, head, ears, eyes, nose, throat, tracheal deviation, JVD, checking the cervical spine, down to the clavicle, scapula, down to the ribs, sternum, right? Chest rise and fall. Get a good set of lung sounds. 6 in the front if you have the ability to get the back, then 8 on the back, right? Abdominal cavity, all 4 quadrants. Palpate the liver. Look for Cullen's Gray Turners. Go down to the pelvis. Palpate the pelvis. Look for pyraprism. Go down to each femur. Right down to the tib fib, down to the ankles. Right down through a full head to toe detailed assessment. Checking the phalanges, right? Phalanges being fingers. Looking at the wrists. Okay. Break it down. Think about what you're touching. Humerus on the radius. There's 8 bones in the wrist itself. You don't have to know the names. 8 bones in the wrist, right? You have which will also be called your carpals. The bones on the top of your hand. There's 5 of them. Metacarpal 1 and metacarpal 5. In your fingers, they're called phalanges. And inside the fingers, 3 different bones in your fingers, 2 in the thumb, right? So again, going back to human body, we have they're called a phalanx per finger. And the fingers have a distal, medial, and proximal phalanx, and your knuckles that are there. Then break it down even more. In your knuckles, you have different fluids in your joints, the synovial fluid. You look at your thumbs. Your thumbs sit on joints called saddle joints. Your knee is a hinge joint. Your shoulder is a ball and socket joint, right? So look at all those different things on the human body as you're doing your assessment. And during your practical time you have with us doing, like with Morgan up at AVH, I'm assessing the shoulder. I'm assessing the acromion process. I'm assessing the shoulder, the humerus, going down to the elbow, checking the ulna, checking the radius, checking the carpals, metacarpals, checking the phalanges. Get used to using those medical terminology. Have that verbal diarrhea. That's what I call it. And verbalize everything you're doing and everything you're touching. Because when you're in your assessments, your practical stations for the state, if they're looking at the clipboard and you touched it and didn't verbalize it, it didn't count. So again, I just rattled off a bunch of human body stuff, but those are basic level bones that I just mentioned to you.
Right. But is that part of your secondary assessment or is it before the second? Okay. It's part of the secondary.
Correct. Your head to toe your rapid trauma, which is what used to be called back in the day.
Yep. That's part of your primary.
Right. That's part of your primary assessment. Airway, breathing, circulation, rapid head to toe, right? That's going to determine, is this patient really sick or not sick? Do we need to load and go, or can we stay and play a little bit, right? Do we need to call for ALS, right? ALS indicators, femur fractures, pelvic fracture, any kind of arterial bleed, anything that has to do with respiratory or chest pain or cardiac in nature. If you have Cullen's or Gray Turner sign noted, a bruising on the flanks or around the umbilicus, based on trauma, basilar skull fracture. So again, battle signs. Look for those different things that potentially could cause a patient to go unresponsive. That's what you're picking up on your rapid, right? Now, if a patient has an ankle fracture, we're not going to splint that on a rapid trauma assessment because you're not going to die from an ankle fracture. But you can die from a pelvic fracture because what did Morgan say? How many liters of blood are in the body?
I can all go there.
6.
6.
Right? 6 liters. Your pelvic cavity can hold 3 liters of blood. That's half of your adult blood supply going into your pelvic cavity. Do you think you'll be hypovolemic if that happens? Everybody should be saying yes.
Oh, I
Hypovolemic
did,
shock
yes.
will happen. Right? I'm sorry, I really can't see all your cameras. I'm still driving.
Oh, sorry.
Each femur can hold up to 750 mLs of blood. That's enough to put you in the shock. So rapid trauma assessment, vital signs, get your sample history. If you can, if anybody's around to get it, get the patient in the back of the ambulance and do your detailed en route to the hospital. After you're done with your detail, do your reassessment and vital signs every 5 to 15, depending on stability of the patient. Right?
Thank you.
But yeah, you're welcome. Hopefully that answered everybody's question on that.
Yeah.
And then use monitoring devices like the Zoll or the Philips. Right back, I had so reassessment. How often do we reassess patients? 5 or
10 to 15.
5 if
5 or 6,
they're unstable, 15 if they're stable.
right? So like once you like assess, it's pretty much time to start over again and just do another head to toe and take vitals. Like the Zolls are really good about you can just set the time and then let it rip. Reassess the patient's vital signs. Like every time you do an intervention, you should be checking vital signs and reassessing if that intervention is working or not. Reassess the chief complaint and ABCs and the mental status if it's improving or if they're decompensating. Reassessment continue. Determine what interventions are needed. Focus on supporting the cardiovascular system because that's the pipes, the pump, and the fluid. Treat for shock early and aggressively. Provide oxygen and keep the patient warm. And you can put them in position. Like if they're on a board, put their board on blankets. Like get it up off the supine. How about we take 5 and then we'll come back. So it'll be 20 after.
Hey, Morgan, did you get my email?
I did. I was going to say something. I was touch with base with Scott and I'll email you again.
Okay, great.
Okay, 5 minutes, 10 minutes.
I was going 20 after 5. We got a lot to go still.
Yeah, that's fine. Okay.
Well, we still have about 3 minutes left. Anybody have any questions for me at all before we move forward?
Kevin, not a question, but the the motorcycle accident with the helicopter incident. So Bob was there and he was the first on scene, the medic, got
Yep.
all the information as far as like what happened, so he had already done primary assessment almost a second, like he basically had all the information he needed to know. What information wasn't readily accessible was who he was, like all his like personal information, date of birth, like anything, like where nobody knew who he was. And so the group Fishtail, who was the motorcycle group that was coming in, they had a list of people who were riding. So it was basically a delay in finding the person who had that list, because nobody who knew who that guy was, because it was
Right.
So that was the information that was missing, because when cameras got there, and I think when they were already bringing him down off the track in the ambulance. So like, I guess what I'm trying to say is they were trying to get the information that was already known. You know what I mean? And people were like, "What do you mean?" And so it was almost like, because it wasn't a normal like car accident on the road where everybody shows up at the same time. You know what I mean? There was already an assessment done. Already, this guy's got to go. He's already been given a diagnosis, or what could potentially be issues. So I think a lot of people, when they got on the scene, they were thinking that they needed to find all this information out, and so it was literally making it almost like a circus, because people were asking questions that, like, I'm like, now, and I wasn't there, but I was getting secondhand information, but I was like, I said to Bob, I go, Bob, why were they looking for information when you already had it and you already assessed the situation and determined, what the next steps would needed to be. But like I said, finding out who he was and date of birth and all that was the difficult part of getting hold of that one person who had the master list to find out who he was. So they're going to change that, because I'm like, that's so silly. We should know exactly where everybody is on site. Like, they should be given a site number and a position where they are, and
Oh, exactly.
But
at the
it's
but
almost
at the
like,
end of the day, not knowing his name and age is not going to change the way I treat him in the back of the
Right.
ambulance.
Yep,
But
that's it. And
it's something. But again, he also got transferred to another hospital. I don't know which one he went to, nor can we talk about it in class, anyways. But he was still transferred. It would have been nice to have a name, which we
Right.
got eventually. But still,
Yeah.
I came in late in the game. I was coming from North Conway, coming down.
right. Yeah. So
I think we're back in session here. So
yeah.
Everybody ready?
There he is.
Yep, I'm here. I was listening. Anybody have any questions so far? Yes. Oh, there's a kitty again. Squirrel.
That is one big cat.
I know.
This is Mr. Salem, and he's very sick right now, so all he wants is his mama.
Aw.
He has
Okay.
pancreatitis. He is. He has pancreatitis. So every 2 or 3 times a year, he just can't stop throwing up. And unfortunately, it takes an act of Congress to try to get medication into him. So he has to go
That's a puppy.
multiple days without food and water. I mean, all he can have is water. So
Fred,
Anyway,
who's your buddy?
This is Libby. This is my good
Aw.
girl.
aw, see, EMTs, pets can be EMTs too. They're like therapy animals.
Yeah,
Oh yeah.
They're a little bit of a distraction.
my
Right.
two are sacked out on the bed.
All right, we'll get back into shock. So keep going.
Yeah.
So as the treatment of shock, we follow our standard precautions. We definitely BSI gloves, and every time you have a spare set of gloves because on every trauma scene they will just disintegrate for whatever reason. Control like eyewear, mask, surgical mask, or a face shield. Because you don't want stuff spurting in your face, mouth, and eyes. Control all obvious bleeding. I would control like spurting bleeding before then move on. But if I saw venous bleeding, anything gross, I would probably tend to. But if it's like minor cuts, I'll just probably move on and take care of it later while en route to the hospital. Maintain manualized stabilization, check breathing, pulse, and circulation, like our ABCs. Comfort and reassure the patients. We're going to do everything we can. Don't give them false hope, though. Don't feed them BS. We're just doing everything we can. We're going to get you to the hospital where hopefully you'll get definitive treatment. Never allow patients to eat or drink prior to being evaluated by a physician. But that's in case if they have to go to the OR, or you don't want them vomiting either. And they will, if it's severe, they will start saying they want something to drink. Just don't give it to them. If spinal immobilization is indicated, splint the patient on the blackboard and make sure it's secured. Provide oxygen and monitor the patient's breathing. Just because you give them oxygen doesn't mean that they're not going to decompensate. Place blankets under and over the patient. Because like in the wintertime, the stretcher is pretty cold. And so it's good to, we crank the heat before we get there, but it's always nice to, and like I said in class, like on Sunday, we have a provider, especially on old ladies. He will always put like a towel or like over their head and they'll put a blanket around their shoulders, and then a blanket over them. Because that's one of the biggest places we lose heat is our head. But we just need to make sure they're warm. Reassess the patient's vitals every 5 minutes through treatment and transport. Treating cardiogenic shock their pump is failing. Like the balloon is like a big balloon, a little balloon. If they're a little balloon, they're not going to be like getting that pre-fill, or they're not going to be able to push it through. So patients may present with chest pain. Patients should not get nitroglycerin with cardiogenic shock because you're just going to make things worse. I don't know how to do that. Anyways. They'll usually have low blood pressure, or they'll have a narrowing pulse pressure. Weak irregular pulse. Sure. They will have a weak pulse because it's not pumping properly. I guess this is the cyanosis. Tina was right about the lips and under the fingernails. They will be anxious because they're shocky, and they'll be nauseous.
So we're now in the decompensated shock, correct? These are
No, not necessarily, because if you think about it, like they could have low blood pressure because their pump is not pumping, or it's pumping irregularly.
okay.
Like that's where the trauma or the lungs pushed the heart over, or it's just filled with fluid.
Okay.
Like I guess there's really no like definitive line of like, oh, now they're in compensated shock, now they're in decompensated shock. It's just something like they'll start trending one way, then they'll just reverse and start trending another. So we'll place the patient in position that ease of breathing. Usually that's sitting up, hold upright, because you want gravity to be your friend. Assist ventilations when necessary. So if you do have to use the BVM, it's the best if they're laying down, but do the best you can with what you have. And provide prompt transport. Cardiogenic shock is one of the hardest shocks to treat. Like if they're lacking fluid or blood, we can give them fluid, or they can get blood in the ER. If their vascular system's messed up, we can give them norepi. But like cardiogenic shock, it's kind of tricky you don't want to damage the heart more because it's a damaged heart. So it's kind of a tricky thing to treat. For cardiac tamponade, increasing cardiac output is priority. We're not going to do it. They just need to get to an OR or the ER. Apply high flow oxygen, and see surgery is the only definitive treatment. Like that, Kevin was talking about the long needle that they glide up the rib until they get PVCs, and then they get blood. Again, tension pneumothorax, high flow oxygen. Did they talk about using a BVM on pneumothorax at all? No.
So
It's not the best idea because it blows oxygen in, but so high flow or air in, it just pushes it more.
yeah.
So high flow oxygen and the chest decompression, so ALS or get to the ER. Check septic shock. Again, it's distributive. Hospital management is required because I need antibiotics. Ventilatory support may be necessary. Use blankets. And you can call a sepsis alert, and so the ER is ready. And they'll have like everything ready to go in the ER. Neurogenic shock, provide mobilization, obviously, adequate breathing, make sure because if depending on where the injury is in the spinal cord, like if it's between C4 and C5, you might be breathing for them, or C5 and C6. Ensure that they have adequate circulation. It was one of my first traumas. It was like a neurogenic. Treating anaphylactic. This is something that you definitely can do, life-saving, is administer epinephrine. And like as soon as if they say they have an allergy or you see the swelling and you hear that stridor, remember we listened to the stridor, that high pitch, just give it to them. A mild reaction may worsen suddenly. Request ALS if available. Yes, always request ALS. Treating psychogenic shock. Put them in Trendelenburg's position. Like they're just gonna faint. So yeah, and once there's just blood flow is not restored to the head, it will they'll come back to. So that if you've ever had a patient like I'm afraid of needles, and then they have to get their labs drawn or they have an IV started and they pass out, or if their loved one suddenly passes away, they just kind of lose it. That's kind of, and usually they'll come back to on their own. If they do fall and like crack their head or something, you got to make sure that their neck and back are intact. And they don't, if somebody who might be on blood thinners, like we got to make sure they don't have a brain bleed. So hypovolemic shock, we want to control all the bleeding. If there is any, keep the patient warm, recognize internal bleeding, and provide aggressive support. How would you be able to tell if a patient's bleeding internally?
Discoloration.
You could have some bruising.
Bruising. Bruising is usually kind of a late sign.
Mm.
What about the
Blood.
abdomen? What does the abdomen do if there's blood in there?
Rigid.
Distended.
Yep, it
Distended,
becomes
rigid.
Yep. They'll look shocky. They don't know why. Transport as rapidly as possible. You can put them in a position like in Trendelenburg's, keep them warm. Treating for shocks in older patients. Older people, they have more complications than younger ones because, well, younger ones like have the ability to compensate better than older people, and their vascular systems isn't full of plaque, and they're not on a lot of medications. Many patients take medications that mask or mimic signs of shock, like a beta blocker will mask signs of shock. Like it's like somebody's bleeding out, but their pulse doesn't go up. Like check their medical alert or their past or for medications. Anything that ends in like OL, metoprolol, is a beta blocker. So we're on review. Any questions about shock? I know it's a lot. We'll go over it because there's trauma, which we'll just talk about it again and again.
Okay.
Any questions? Do you guys know what the difference between the distributive, obstructive, the three different mechanics that are involved? The pump, the fluid, and the hoses, vascular system.
Yeah, I think.
So, the term shock is most accurately defined as a decreased supply of oxygen to the brain, cardiovascular collapse leading to inadequate perfusion, decreased circulation of blood within the. What's that?
I'm going to say
Decrease
B.
B. I would go with B. Yep. Shock or hypoperfusion refers to state of collapse and failure of the cardiovascular system. Yep.
Can I ask a question?
Oh, absolutely.
How does everybody want these to be answered? Do you want us to do it messaging? I'm slow, so by the time I get to the message and put it in, does anybody mind if I say my answer out loud?
I'm not shouting out.
All right.
If everybody else wants to do that or okay with that.
Yeah.
Or if you want to type it. So anaphylactic shock is typically associated with urticaria, bradycardia, localized welts, or severe headache.
Hey.
Hey.
What's urticaria?
Hives.
I don't know.
Hives.
Hives, like global hives, head to toe. Hives, yes. Signs of compensated shock include all the following except restlessness or anxiety, pale, cool, clammy skin, a feeling of impending doom, a weak or absent peripheral pulses.
So here's the question. So it says signs, right? Not symptoms, right?
So it's what we're seeing.
I would say
I'd say
B.
D.
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 Right. So they can feel restless or anxiety like right from the get-go because of the adrenaline pumping in, and they know something's wrong. Pale, cool, clammy skin can be more like right from compensated to decompensated. Feeling of impending doom goes with the restlessness, anxiety. So yes, weak or absent pulse would be actually decompensated because that means their blood pressure is shutting down. And
They could be feeling the impending doom, but there again, it's a symptom, not a sign.
Right.
But no, it's
That's it.
everything except the except
Right.
is the key thing
Yeah.
here. So
Right. D. When treating a trauma patient who is in shock, lowest priority should be given to spinal protection, thermal management, splinting fractures, notifying the hospital.
C.
C. Yes. Unless it's a
Yeah.
femur. B. Because the hospital's going to want to know so they can get their trauma team and radiology or whatever they need. Potential
Going
causes
back-
of cardiogenic. Oh, what's that?
Back to the third question.
Oh, sorry. Potential causes for cardiogenic shock include all of the following except inadequate heart function, disease of the muscle tissue, severe bacterial infection, impaired electrical system.
I would say C.
C.
I would say C too. Because that's something else. A 60-year-old woman presents with a BP of 80/60 millimeters of mercury, a pulse rate of 110 beats per minute, mottled skin, and temperature of 103.9. She's most likely experiencing septic shock, neurogenic shock, profound heart failure, or severe viral infection.
I would say A.
A.
so it's either A or B. So
A.
I'm gonna go A.
A. Yeah, I would go with A.
She has
That's the
she's
signs
two
that
of the, at
everyone's-
least two of them.
She's like really sick. Yeah, so low BP, tachycardia, fever. That would be septic. The patient with neurogenic shock would be least likely to present with tachypnea, hypotension, tachycardia, altered mental mentation.
Slightly.
I always pick the one I don't know that. I say A.
Tachypnea. You don't know what that means?
Fast
I do if I break it
respirations.
down.
Okay, so what's tachy?
High or
Fast.
fast,
High,
rapid.
fast, right? What's apnea?
Breathing.
Breathing.
Breathing. So fast heart breathing rate. This is a tricky
Hypotension
one.
would be low blood pressure.
Right,
Tachycardia
So-
would be a fast heart rate.
right.
And then altered mental status. The least like
C.
no,
Oh,
I
this
think
is-
it would be D.
I would go with D. Because
All right.
like
D.
neurogenic shocks, they generally start to breathe rapidly. Do they?
No, I didn't think so.
Because it depends on where it is. If it's C4, C5, like
Yeah,
that's
but
when they're breathing with their
But you
diaphragm.
usually have to, yeah.
All right. Let's.
So
I'm gonna go back and look.
hypotension.
Patient with
Oh.
neurogenic shock would be least likely to present with a rapid heart rate.
So they're definitely going to be hypotensive because their
Right,
vascular
blood pressure's
system's
going
opening
down.
up. They're going to be compensating with tachycardia.
Yeah.
Maybe they may
All
be
right.
not being altered.
I see.
So
See it.
it's going to be between A and D.
Booster.
I think we're going to go with.
I'm
I'm
saying.
going to go with D.
I think it's D.
Stick with it.
I'm going to go with D too. C.
Oh, dang.
It's weird. Looks like I'm gonna have to
Oh, that's
review
right.
neurogenic.
Apparently, I need
I
review
wish,
too.
why can't they have regular names? Why do they make
So-
the name so hard to pronounce?
What's that?
Why do they make all the names so hard to pronounce?
Which names?
All the
Leukemia and-
medical
yeah.
terms.
You get used to it the more you talk about it. So I guess apparently it can't dump the norepinephrine and epinephrine into the body because your adrenal glands are on your kidneys, and so like it will block that, and so we won't be able to.
So can you bring the question back up again?
Sure.
Patient would be least likely to.
That makes sense.
So they would not have a rapid heart rate.
Correct. Because their body won't be able to dump the epinephrine nor norepinephrine in.
I mean, that's assuming that the actual injury is high.
Right.
It's below the injury that pretty much doesn't do anything.
Right. Well, that would, yeah, it would be pretty high. But that's where usually they are, though.
Yeah, yeah. Well, that's why I picked C. But
Yep. Huh, that was new to
I'll
me.
never get that question wrong again.
Me either. A 20-year-old man was kicked numerous times in the abdomen during an assault. His abdomen is rigid and tender. His heart rate is 120 beats per minute, and his respiration rates are 30 per minute. You should treat this patient for a lacerated liver, a ruptured spleen, respiratory failure, or hypovolemic
B.
shock.
B. I'm gonna say B.
B is in Bravo.
I would say
Yes.
D.
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 only because we're learning about shock.
Right.
mean-
what are you gonna
Yeah,
do
I
for a
know.
ruptured
Well, that
spleen?
and he's probably bleeding, and I mean he could
All
be
of the
bleeding.
above.
He could be bleeding from the spleen or the liver.
So he's definitely in shock. We can all agree with that with his heart rate and his breathing.
Yeah.
Yeah.
We don't know where he was kicked, or rather just in his abdomen.
Wow.
So
Rigid and tender's kind of
And
a
it-
clue
right.
for me.
Rigid.
rigid.
High
So his
heart
blood
rate,
in his
right,
abdomen.
right.
So you,
Yeah.
you got to assume something's bleeding. So he's
Right.
losing volume.
Right.
It's going
So,
somewhere.
question for you then. I have a question for you all then.
Okay.
How would you know?
Okay.
How would you know it's a ruptured spleen?
When you palpate the side the spleen's on in the abdomen, the right side. That I'm gonna say, is it the
So-
right side?
I think it's
Splenic injuries
the-
have something called referred pain. Okay,
Say that one.
they would have referred pain. So they would have right shoulder pain if they have a splenic injury. And that's what they call Kerr's sign, Kerrs, Kerr's sign. So Kerr's sign would be shoulder pain, along with potential Gray Turner's sign as well for the splenic injury on the side, with referred pain to the shoulder. So it's called Kerr's sign.
So what about
Look
if
it
it
up.
was a lacerated liver? Is there referred pain for that?
There's a name for it. I can't think of it off the top of my head.
Okay.
But
I still
remember
say
that-
it's D.
Yeah, it's gotta be. That's what we're learning
It's
about.
got to be. Because
Right.
it doesn't matter which one is ruptured, he's bleeding. So he's losing volume
Good point.
and he's in shock.
Yep.
So
Right.
I'm going with Jen.
Yeah, hypovolemia.
The patient
All
may
right,
have
so- So hypovolemic is loss of blood or fluid,
right.
rapid weak pulse, low blood pressure, change in mental status, cyanosis, cool, clammy
Yes.
skin. Good job, Jen. That was probably the easiest question that they made, because you put shock after it. We're gonna pick that answer.
I actually went through process of elimination. I didn't even do it that way. But that's okay. I'll take my whiplash neck brace off for right now.
There you go.
Don't
Uh,
read into the questions.
Yeah. A 33-year-old woman presents with generalized rash, facial swelling, and hypotension approximately 10 minutes after being stung by a hornet. Her BP is 70 over 50 millimeters of mercury, and her heart rate is 120 beats. In addition to high flow oxygen, the patient must be in immediate need of A, epinephrine,
A.
B, rapid transport. Yes,
Okay.
A.
A.
I would say A. And then B.
Needs an EpiPen.
And then D. And then, yes.
B.
You get A for you guys. That's because we want to mimic. Any questions about that one?
No.
No.
The following are potential causes of impaired tissue perfusion, except increased number of red blood cells, pump failure, low This is a gimme. Low fluid volume, poor vessel function.
Say A.
A.
I'm not sure that's
Well,
right, but A is the only one that kind of makes sense.
we learned
learned
about,
about
we learned about
all
low,
three.
yeah. I was
What's
gonna
that?
say all three bottom ones, yeah. We learned about all the three, B, C, and D. That was never mentioned.
Right.
Right.
It's kind of like process of elimination.
And that's how what's his name won the Tour de France like 7 times.
Oh yeah. Lance Armstrong.
Yep.
Blood dope.
6 times. So increased number of red blood cells.
Called blood doping.
Blood dope.
Yep.
All right. Let's take 5, and then we'll go to
Pharmacology.
pharmacology.
Sounds good.
Morgan, how many slides is this one? I can't remember off the top of my head.
82.
So about what, 55 or 60 before getting review questions?
Yep.
Should be able to get that done in an hour then.
Yeah.
What were you guys just talking about? Questions on a test? What were you talking about? Questions on a quiz or something? I heard.
What's that?
What were we just? I just heard somebody talking about.
No, he asked me how many slides were in a
Oh, all
presentation.
right.
That's right. We have our exam on Thursday.
You still
Way to
on?
come with good news.
And these two chapters we're covering tonight will be on the exam.
So it opens in the morning and it closes at like midnight on Thursday.
Yeah, so 8 o'clock in the morning it opens, it closes at 11:59 p.m.
Figure out how many questions you're gonna do. Yep.
There are questions on the exam, yes.
Thought there was a 2-hour time.
Wasn't it an
I did
hour and a
put it-
half?
That's 2 hours if you go to the
Oh, okay.
exam one. If
Yeah,
you click on it,
I gave
it's
a 2-hour time limit on it.
Thank you.
That means that don't take it at 11:50 p.m.
Because it's gonna shut you
Unless you
off.
can do it fast.
Right. And the next thing is don't walk away from your test, because once it closes, you can't reopen it.
Is that Eastern
Right.
Standard Time or is that Pacific Standard Time?
Whatever you want it
Daylight
to be, I
savings
guess.
time.
And
Whatever time
plus,
you
we
wanna
have
wake
our
up in the
lecture in the
morning.
middle of it.
That is correct.
And it's going to cover all the chapters we've gone through, right?
Everything up until today, up including today.
Including today. Okay.
Including today's lectures, yes. The
Morgan, can
sectional
you take the
exams,
test with us?
I don't know if you
This-
want me to do it.
the sectional exams are done by the sections we're currently covering, and the class final is fair game for every chapter.
Say that again.
A sectional exam only covers the section we're covering between exam dates. The class final is open game for every chapter we covered.
Okay, got it. Yep, that makes sense.
So I don't do midterms anymore. So I do more sectionals. It gives you more chances to get better grades. And your exams are worth 50% of your final grade. You need to study. Look at previous quizzes.
What about that
Right.
app that you had us download? The Kahoot.
So the app that you guys downloaded are not going to be questions you'll see on my exams. But the things you see on test prep on AOS, you might see some of those pop in on there. but the apps are good for the National Registry passing.
So when you say, what'd you say, AOS? Is that the Jones and
Your
Bartlett?
your JB
Yeah,
platform.
So if we
Test
did
prep.
like
Do the test preps.
if we did the test preps, yeah. Has anybody done the test prep? When I pulled it up,
Yeah.
it came
Not
up
yet.
with like 125 question test, and I didn't have time at
Oh.
the time to finish it.
Yeah, I didn't
No,
have time.
so that's different. That's your assessment exam. That's kind of like taking the National Registry.
Right, your
Create
test
own
prep is
exam, and
putting,
create your own exam. Don't do the assessment one. Do the one above it.
so where you basically,
Great.
like Kevin was just saying, you take questions from all different areas that we're gonna test on, answer them, and then you'll find out where you're deficient. Then
So
do it
when-
again.
Your
different
assessment test
questions.
is like a National Registry. You do one question at a time. And at the end, it gives you a final grade, but it doesn't tell you where you got things wrong.
When I did the create new practice test,
That's what you want to do.
how does it
Go
know?
into there and select which categories you want. So let's say like cardiac might have like 80 questions. Put down 20 and hit add, and 20 questions will be imported to a test.
Oh, I see it. Yeah.
Yeah.
So
and you can make
mine
your own
only
test
has
that
like
way.
mine only has 1, 2, 3, 5, 6 choices to pick from, other than all subjects.
Right, but there are six categories. And those 6 categories are things that you're tested on in the National Registry.
So it's not chapters, it's categories.
Correct. Yeah, the National Registry does not test on a chapter. It does cardiac,
Right.
respiratory, pediatrics, obstetrics.
Yeah, it
So-
says airway and breathing, cardiology, medical, obstetrics, and pediatrics, operations, and trauma. Those are the 6 that you can
Correct.
choose from.
So if you go to trauma and type in, let's say, type in 10 and hit add, it takes 10 trauma questions and puts them into a test bank. So you could do like, for example, obstetrics, trauma, medical, right? You put 10 of each, and you just created yourself a 30-question quiz. Go in and take it, and each question you get right or wrong, it gives you the like the prognosis of what you've done. It kind of goes over it with you.
And I think it tells you the page number that the answer's on, or where you can find the.
Exactly. Yeah. It kind of goes over the question with you and kind of like a review.
So
Do those
Jason, where are
first.
you finding that? Because I'm not seeing the create my own test or create my own quiz.
Shit, I just shut it down.
Oh,
Are
it's
you,
all
are
right.
you in?
You gotta
Go
go.
to JB Learning, click on test prep, and then open up the link in that folder, and that'll bring you to where you need to be.
So when you hit launch, it's like the very next page that comes up.
Yeah, on the left hand side it says exams, quizzes.
Okay, I didn't go far enough. I just where it said test prep. I didn't go the next level. So I didn't see that there were like 4 options once you click the next screen. That's what I was missing.
Okay.
So I'm good. I see it. I see what you're talking about now.
I started the assessment and I got all 16 questions right, and then I stopped because I'm like, I can't sit here for another hour and a half. And